My practice is very much half and half, a half double jaw surgery and a half joint surgery. I do between 90 to 100 cases a year. 20 to 30% of what I do in my practice is revision of double jaws.
Wow.
Which is, yes, and it's harder.
Are a lot of those revisions, doctor, related to the fact that that patient really needed to address the joints initially and it was neglected, and so therefore there was some sort of relapse or continued deterioration of the maxillary structure related to joint health?
Correct. I've had 3 jaw surgeries. I had 2 double jaw surgeries that failed because I had a joint that was broken down on one side. The condyle just wasn't seating. When I would wake up, the bite is off. Midline wound up being off. Then ultimately we realized, I should have realized that for myself. I needed a total joint upper jaw. Okay. And this was all for OSA. I would do another surgery or 2 surgeries if need be to get to the airway that I have right now because I couldn't imagine where I would be without it. Everyone thinks that this joint will break in 10 years. And it couldn't be farthest from the truth. Not a single one of these, Ron, not a single one of these have worn out after 38 years of the company being around. If you're an oral surgeon and you're not doing total joints now, knowing that what can transpire and what is possible with total joint upper jaw, you're shortchanging your patients and you're no longer the end of the line.
Well, Dr. Movahed, thank you so much for joining me today. It's an honor and a pleasure to have you. You're a legend in the field. It's a name that I've been hearing for many, many years. As long as I've been in the space, I've been hearing about Dr. Movahed. And I just want to come right out and ask, how many jaw surgeries have you done? I'm trying to gauge your sense of your experience in this space compared to a typical OMFS. How much orthognathics have you done? And then how many joint replacement surgeries have you done? And then tell us, how is a maxillofacial surgeon who does joint replacements different than someone who just does double jaw, which the double jaw is something my audience is quite familiar with. Sure. But joint replacement is a completely new concept. And we haven't had anyone on who's discussed that. So give us some perspective on how you fit into the field of other maxillofacial surgeons.
So, number one, it's a privilege to be oral maxillofacial surgeon, especially now at a time that I think a lot of what we have is, and what we do, we have a good amount of data for and peer review studies and the science to back it up. And that's the beautiful part about it. And yes, my practice is heavily OSA, joint surgery, and jaw surgery in general. To me, I would say the modern day oral maxillofacial surgeon is a bit different than what it was 30 years ago, because we know that there's so much that's involved in the movement of the jaws and the asymmetry of the jaws and the dental facial deformity that originates in the joints, whether it's congenital that the joint on one side is missing, whether there's a tumor that grows on one side that moves the jaw to the other side. So in a lot of ways, previously, we were trying to mask all of that by just moving the jaws bony structure wise, rather than going to root cause of the problem. So that's what's changing, just to ignore something that's the cause of a problem. For example, if a tumor is growing in the joint, and a benign tumor, we're talking, there's multiple varieties of growth, condylar hyperplasia that can happen in joints, for example. But the most common one, for example, is osteochondroma. And if we want to gain real symmetry, you have to address the source of the problem. And also, if you don't address the source of the problem and the tumor grows, the jaw becomes more asymmetric. Or even you correct asymmetry, you have a chance of relapse because of the growth that can happen on that side. So you have to address that. And also, there's a whole lot of detail that you can get into with a vertical ramocyte, so on and so forth, which I'm sure we're going to have a chance to talk about. But yes, to me, a modern day oral maxillofacial surgeon, contemporary orthodontic surgeon has to involve the joint, because we know the benefits of it now. We know that, at least for folks that do a lot of it, we know that, we're familiar with outcomes. We know the limitations, and we're getting amazing outcomes. I'm one of the beneficiaries of it myself. Done about 800 joints, and my practice is very much half and half. half double jaw surgery and half joint surgery. I do between 90 to 100 cases a year.
Is there ever joint replacement surgery? Excuse me for interrupting. Is there is there ever joint replacement surgery that happens together with double jaw, or do they always go together or never go together? What's the relationship between joint replacements and MMAs?
So I most commonly do the total joint split upper jaw, because most of the patient that comes to us kind of like break down. Actually, we were actually looking at this past week because we were getting ready to compile our information for a group of ICR patients who basically we're going to be publishing the outcome assessment that from the past 13 years of doing this. 14 years of doing this. Initially, there was less joint cases that I was doing. And over time, the more confidence that came through, I did more joint cases and became somewhat known for that, because our signature procedure in our practice, in addition to double jaw surgery, which I'm very proficient at, is total joint upper jaw surgery. We gets done at the same time. Because if you're replacing the joints, most of these patients have pitch, yaw, and roll issues in the upper jaw that needs to be fixed. A lot of them have obstructive sleep apnea. And so you're killing multiple birds with one stone. You're giving them function with the joints, taking care of the airway for them, taking care of the tongue space and bite by expansion, advancing them. You helping them with their lip competence. We generally have the 5 criteria that we care about. And that would be making sure that we have lip competence, the airways together, the bite is together, the facial profile, and also the function. Function is so important. And that's the part that we're getting to do. And in a way, being an orthopedic surgeon and saying that don't do total joints. I don't believe in total joints for hips and knees. It's the same exact thing, different kind of cartilage, but it's the same exact thing. And that's helped us so much. So to be a modern day oral surgeon, that does orthognathic surgery and joint surgery, to me is paramount. But it's you have to be proficient at both. You have to be good at doing, and proficient at doing orthognathic surgery and understand the concepts, but also understand joint surgery and also know how to triage these patients. Okay. Who is going to be in the group that is going to need basically joint upper jaw surgery, who's going to be in a group that's going to need just a double jaw surgery or a single jaw surgery for that matter. So we put a lot of time to gather the information to make that decision. And it's not an easy decision. A total joint upper jaw surgery is about 6 to 7 hours, and some a lot more complicated. At 20 to 30% of what I do in my practice is revision of double jaws. Wow. Which is, yes. And it's harder.
Are a lot of those revisions, doctor, related to the fact that that patient really needed to address the joints initially and it was neglected? And so therefore there was some sort of relapse or continued deterioration of the maxillary structure related to joint health? Correct.
And, for us to kind of recognize the pattern that exists, that certain cases that we're mentioning that we're going to move you forward, 10 millimeters in the upper jaw. And the pagonion, our movements on average are between 18 to 25. I mean, this is big numbers.
Yeah.
So some of those are not possible with double jaw surgery. And if you do it, your chance of failure is higher. That's called secondary ICR. That happens with all of those patients.
Doctor, please define ICR, because I think most of my audience will not know what that acronym refers to.
Sure. That's idiopathic condylar resorption. There's an inclusion criteria that we're trying to perfect as well. These are patients who have vertical growers. Okay. That have, as you can see, you had a podcast with Dr. Mandibular. These patients have thinner bone, as far as the periodontium is concerned, which is a soft tissue and bone around the teeth. And, a lot of them have anterior open bites. A lot of them have, osteoarthritis of the joints. They have the anterior disc displacement without reduction, or anterior disc displacement or degenerative joint disease. And the lower third of the face is generally longer. They show more incisors. They will mainly wind up biting on the back teeth. a lot of them. The literature is different. Some would say about 25% of them are symptomatic. Some say about 75% of them have pain of between 3 to 8.
In the joint, or is this craniofacial pain generally?
It's in the joint. And also, so this is something that we have to really talk about, because what happens? You have a joint that's breaking down, and patients are biting forward and the jaw is receding. Patients are trying to bite forward into a good bite. They wind up developing dual bite because they don't have the support that they need in the fossa and the joint where it's supposed to rest. And what happens as a result is that their muscles are holding the jaw together because the bone is not supporting it the way that it's supposed to. Okay. Because, as my mentor always said, joint is the foundation. Temporomandibular joint is the foundation of every bite facial profile. And it is 12, 13 years ago, mentioning this, people will look at you as if you were crazy. But we know that is the relationship between the joint and sleep apnea is heavy, but it's not. If you, for example, you say that I'm correcting the sleep apnea just so the joint should be fine, could not be farthest from the truth. It's a dual connection there.
Do you think it's a fair analogy to say that the joint is like the foundation of the home, where if the joint is resorbing and otherwise deteriorating, I'm not sure I have the technical terminology to describe the deterioration correctly. If resorption is the appropriate term, then great. If not, you can correct me. But
that's okay.
It's like building a house on beach sand, right? Where, this is the A point of the maxilla and the pogonion, let's say, might be like the roof of the house, but it's sinking down into the sand because the joints are resorbing. And so no matter what you do here, the foundation continues to sink.
Exactly. And you can, we have a whole lot of talks that we've had, amongst providers that you're going to stabilize the joint and the joint is going to be fine and so on and so forth. That, for example, even in the world of joint surgery, we talk about, it used to be 15, 20 years ago, we said, we're going to do arthrocentesis and arthroscopy. Now the joint is stabilized, then you're okay to do the double jaw surgery with no issues. Or we use splints to get the joint in the right position. It's going to be fine. The double jaw surgery is a traumatizing, effect, has a traumatizing effect on the joints, whether you like it or not. That's the fact. We know between 17 to 21% of the condyle could resorb because of a double jaw surgery, because of a sagittal split. Patients that have just wisdom teeth extracted, a lot of them wind up with disc displacement. And some of them that have disc displacement, they don't wind up having no noise, but that means that the disc, the clicking that they had has gone away because the disc is out of place. And now the patient is functioning on retrodiscal tissue. Double jaw surgery has the same effect. Some of the literature that we've had, about 50% used to say that about 50% of patients who had double jaw surgery, the joint issues go away. They don't have any clicking and popping. But actually, that is not a good thing. The problem is that they had clicking and popping because the disc, whenever they opened up, would go back on the head of a condyle and they'd hear the click and pop. Now the double jaw surgery, basically separating the proximal segment from the distal segment, which would be condylar bearing and the tooth bearing separated. You're doing this. You're moving that whole segment up and down. That's very traumatizing to the joint that is not used to go in these directions. Okay. So then they don't hear any more clicking and popping, and they think things are better, which could not be farthest from the truth. The fact is that the disc is even further displaced, and it's not reducing anymore. Now you're not functioning on the protective mechanism that's present for the disc.
Are patients that go into jaw surgery with no prior, let's say going to double jaw surgery with no prior TMJ issues, will they develop TMJ issues after jaw surgery? Is that what you're saying? Is that jaw surgery is
not all patients, and that's something that we really should discuss. There's a very small group of patients that have that issue, and that's mostly class 2 patients with a high occlusal plane, with anterior open bite, the vertical growers. That group, majority of 80 to 90% of double jaws have no issues whatsoever with any need of doing anything with the joints. None whatsoever. There is the class 3 cases, for example, that the lower jaw is forward, upper jaw is back. The occlusal plane for those patients are flat. The condyles are robust. And there are multiple things you have to look at. Mostly it's females that have issues. It is, you can notice that early on if they have TMD issues ahead of time. Plane of the bite is steep, as I mentioned. The upper jaw and lower jaw receive the class 2 morphology. Those are the patients that are at highest risk. But we also do MRI. We do look at the CT scan. We look at the MRI. We built the case for doing that and triaging these patients for the appropriate procedure. Because we can go over a number of cases. I can show the revision cases that we wind up doing that the surgeon should have picked it up.
Picked what up specifically? Picked up the risk to the joint?
The fact that the double jaw was not going to be a stable procedure for these patients.
Yeah. And is what you're talking about this CROS concept that you were telling me about yesterday, condylar resorption from orthognathic surgery?
Sure.
And you're saying that this happens to roughly what percentage of patients, but mostly to a specific kind of patient, and you describe the phenotype?
Yeah, very small group of patients. It's a 5-to-1 female to male, basically proportion is, predilection that you can come across. These are the patients who already have resorption in their joints. These are patients who have disc displacement. These are patients who have high MPA, and that means that their lower incisors are so proclined. Okay. Because the lower jaw is going back. So the lower incisors are trying to meet up with the upper jaw. So the lower incisors are proclined. These are patients who have a smaller airway also. And these are patients who lost a lot of ramus height. Okay. And that the only way to, for example, if the ramus height is going up, the only way to recreate that, because the double jaw surgery brings this part down, right? Even if you do a reverse L, you're not going to be able to bring the angle in the right place. Mm-hmm. You can't graft on everything else that you want, but that's not really doing a lot of work to duct tape a geo together to keep it going, or a car that's breaking down that needs the whole structure changed. Mm-hmm. Why aren't we going just to the position, to the root cause of the problem, for example, to restore the vertical height? And that's where the shortage of a double jaw surgery is. Double jaw surgery is a powerful, amazing way of approaching dental facial deformities and asymmetries for that sake. I do a lot of it, and you have the capability of doing that. But the part that I have issue with is that orthodontic surgeons should be familiarize themselves with what's going on with the patient's joint, because a lot of patients, at least in the cohort of patients that I see, these are folks that come in with joint pain, relapse double jaws, and this is the best procedure, fits them. The quality of life outcome for them are great. I follow my patients. I have 13-year follow-ups at this point. Okay. Our joint cases are stable. I don't see my patients. I follow my patients every year for 5 years. Then I follow them for, 2 years afterwards. And my doors are open for all the patients to come in. We call them to come in. A lot of them don't come in because they're living their best life. Okay.
Why do so many OMFS avoid the joint, and why is it so scary to these amazing surgeons who do these incredible double jaw surgeries, and yet still there's this kind of monster, which is the joint, that they really don't want to open up and confront? Why is it so scary?
They're not trained. They are not trained. And they don't know, in a lot of ways, they don't know the facts that's involved with that, Ron. It is, if you spend at least a couple of weeks in our practice, you see, we brought patients who are broken down mentally, physically are dealing with elements of, relapse or just TMD issues, and basically these are the patients that we're rehabilitating. So it is a heavy lifting. It takes much more, not to put down double jaw surgery. Double jaw surgery takes a lot of skill to do it right, but total joint, yes, it is. You're working around the facial nerve. You're working around some major vessels. It's basically a deep plane facelift, incision that you're right around very vital nerves and vessels. So yes, most oral surgeons, one a 3 hour case versus a 6-7 hour case. But the right thing to do doesn't qualify. Oh, this is a lesser surgery, so I'm going to go for the lesser surgery, and it could relapse. But you're not going to do that. If your success rate is lower, you're going to go for the procedure that's going to give you the longest stability, longest term stability.
Yeah. The more I think about it, the more the analogy that makes sense to me is if you're doing a remodel on a 100-year-old home, let's say, do you bite the bullet and redo the foundation, or do you just build the new frame and the new everything on top of a rotten foundation? And obviously, the foundation being the most important part of any home, you want to just pay once, cry once, take the suffering and do the rehaul of the foundation. That way, all of that money and sweat and blood and tears that you're putting on top of it is going to be sustainable and stable over the long term.
Ron, it is a matter of doing it enough, and you're going to be good at it. Not everyone's going to be good at it. It's not everyone's cup of tea. It's a very intricate procedure. We do it through small incisions. I'll show you the patients on day 2, 1, 2 after surgery. To me, taking the time and treating the tissue nice and do an awesome surgery is the way to go, and the right surgery and the correct surgery. So that is so important for us to realize that it's not a matter of speed, it's a matter of quality of outcome. You can put an IKEA furniture together very fast, but I'm sorry, it's Italian furniture that's going to get passed down generations.
Yeah.
Okay. And that's at the center of this. And now we have a joint that we know what works. The 80s and 90s was a bad decade for joint surgery. So left a bad taste in a lot of people's minds. And unfortunately, our residencies are not all equipped to teach joint surgery. Okay. I had to go and seek my joint surgery foundation and understanding at a fellowship. Most residencies, maybe they do 1 total joint or 2 total joints a year. Okay. Now the numbers are going up because patients are more educated about it. They go to a surgeon and says like, oh, I don't look at the joints. I don't look at your MRI. And we're like, doc, I have severe migraines. Are you sure you don't want to get an MRI for me? It's the same thing for the joint. Are you sure you don't want to get an MRI to see what's going on? We have the data. Why not take a look at this? It's your job to do the investigation.
How does one get trained into doing joint replacement? Who was your mentor that you had referenced earlier? I think I know who it is. But how did you learn this? And would you admit though that the first 50 or 100 of them were pretty damn scary?
Oh, no doubt. No doubt. This is a skill that's, what in surgery we have, was that see one, do one, teach one. That doesn't quite apply for the surgery, I would say. I have a thing about, going to surgery every single time. Even I do my best not to let any of the numbers, and what I've done to get to my head. Every day, my routine is this: the day of surgery, when I walk into my garage, get into my car, I tell myself, treat this surgery like it is your first surgery. A little bit of anxiety is good, and I have a healthy fear of a double jaw surgery, a single jaw surgery, and a joint upper jaw surgery, all in the same fashion, because there's a person on the other side of it. And you cannot, after me having had 3 jaw surgeries.
I'm sorry, on yourself? You've had 3?
I've had 3 jaw surgeries, correct.
Oh, maybe you could tell us a little bit more about that.
Sure. Not a problem. I had 2 double jaw surgeries that failed because I had a joint that was broken down on one side. The condyle just wasn't seating. And when I would wake up, the bite is off. Midline wound up being off. I chose a very experienced surgeon to do this for me. Then ultimately we realized, I should have realized that for myself. And it was about 9 years ago, I had my surgeries, that I needed a total joint upper jaw. Okay. And this was all for OSA. I would do another surgery or 2 surgeries if need be to get to the airway that I have right now, because I couldn't imagine where I would be without it. Glad I've done it, every bit of it. And yes, but it was for me as a patient, it was a very eye-opening experience that I think helped me become a better surgeon and understand my patients better, understand the nuances of this surgery. I changed so much in my practice because of that. And I'm very thankful for this. I had every procedure that I do in my practice, basically, which was not, I'd be crazy to say that that's by design, but in a way, it really helped me become the surgeon I am today.
Do you think you wouldn't feel so strongly about the importance of considering joint health prior to doing a double jaw if it hadn't been for your own 3 jaw surgeries and this kind of oversight occurring on you and your own body? I mean, how the hell did you get through 3 jaw surgery recoveries?
Listen, just, but let me tell you one thing. Once you know, and this is what I tell my patients, do not do surgery with me till you understand every bit of what I do and what you're going to go through. Do not do surgery with me till you understand, what are the movements and what we're doing, and know what you're doing the surgery for. If you are going through this process and you don't know what the gains are, and you're just looking at the aesthetics of it, just for aesthetics' sake doing it, or just also mentioning that, hey, listen, I don't know, I just want to have stronger angles of the jaws and so on and so forth. That's not enough for a reason. There are patients that really do it for the airways part of it, for the bite part of it. Once you know the whys of why you're doing something, then it's easier. Mm-hmm. Then you're willing to go through the rigmarole of the surgery, the pre-surgical surgery stress, the post-surgery recovery and such. And it is a long, arduous process. We embark on a big journey with each one of these patients.
Mm-hmm. As a matter of procedure, you mentioned that the joint in the upper...
Actually, I'm sorry, Ron, one thing else I want to really mention. So I would say that my frame of thought was not changed because of what I went through. Mm-hmm. That was just a separate part of it. I was doing a lot more double jaws in my earlier years, and I wanted to do the ideal movements and such. Okay. And there are cases that I recommended total joint, and I settled for doing the double jaw. I can show you 1 or 2 of those, that ultimately the patients relapsed. And I told myself, I'm not, and seeing that patient go through that, and patients sometimes have a little bit of a short-term memory issue. Okay. Or for that sake, long-term, because we discussed all of these, and the joints were so bastardized to them by other providers that don't understand it, and they chose to do the double jaw. I went along with it. Now, if I see a case that it's a double jaw, it's a joint upper jaw case, and the patient wants a double jaw, I would say, no, thank you. You got to find someone else. Because I know this is going to relapse. I'm not going to have my name on it. I'm not going to see your suffering, because I suffered through some of this with my patients. And it's a much heavier lifting when you take on someone's your own, or just take someone else's baggage. Okay.
Oh, I can't even imagine.
Yeah.
Yeah, to have
picking up the pieces is so much harder. We just had a patient who had 2 double jaw surgeries, and she is just not trusting of the surgeons anymore, and she has a hard time making a decision. And she is in this quagmire. And it's psychologically, it wears people down. So we become the psychologist for the patient. We have to wear many hats. The surgeon, the psychologist, walking them through this. And our consultations are not 10, 15 minutes. I take 2 hours with the patients on an initial consult. And then we have reconsults. Then we have a pre-op discussion, going over the planning and the rest. So yeah, I've seen my own cases that relapse and other folks. And that's what really led me to, hey, we got to engineer this properly.
About how many surgeries do you do a week?
It varies. Some weeks 4, okay, and some weeks 1, and some weeks none.
But you're not doing multiple per day?
No, I do 2 double jaws a day at times, but I prefer not to. I want to give the patients all I have, and that would be all that I can give to a patient. It's rare that we do 2 double jaws a day. I'd rather just do 1, but you can do a total joint upper jaw. You can do 2 of those a day. It's impossible. The surgery time is that, but the prep, because infection is a concern, just like hips and knees for orthopedics. Infection is a concern also for total joints, which can go over the numbers and, what our stats are, but we don't even get started 45 minutes to an hour after the patient goes to the operating room. because we put an arterial line in to make sure before hypertensive anesthesia exactly where the patient is. We put, obviously, Foley goes in, all the pressure pads, typical stuff, triple prep of abdomen because we take fat from abdomen to put in the joint, and also triple prep of everything as far as the face is concerned, inside the ear, and isolating the oral cavity from the joint because that's a clean procedure and this would be a dirty procedure. So there's no cross contamination. So this is real deal orthopedic surgery.
Wow.
And I mean, one more thing to put in is that as oral surgeons, we're at the end of the line for patients. So as an oral surgeon, you got to be able to take care of your own complications. And that's what I was mentioning to you. If you're a oral surgeon and you're not doing total joints now, knowing that what can transpire and what is possible with total joint upper jaw, you're shortchanging your patients and you're no longer the end of the line for these patients.
You have to become the end of the line.
Yes. And that's what I'm saying. The new generation of oral maxillofacial surgeons are learning joint surgery, the ones that want to do this seriously.
Yeah. Well, it makes me think of the fact that a lot of what has made jaw surgery so popular is the effect that it can have on your aesthetics. It can make you a much more beautiful person if it's done well. And I think a lot of what drives some of the more popular jaw surgeons on social media and very lucrative jaw surgery practices is just the double jaw component. And the TMJ replacement component is not very sexy. In fact, it's even more terrifying than the double jaw. It's purely functional. I mean, at least in the short term. In the long term, I think you've made a strong case that it's also important for stability of any double jaw and therefore important to aesthetics.
Ron, actually, it is aesthetic also.
Oh, tell me about that.
It is 100% aesthetic and as well. Okay. This is just a good side effect of it. So your jawline right now, I know you had surgery, but your jawline, vertical height of your ramus is normal.
I have not had a jaw surgery.
Oh, you haven't had jaw surgery?
No, I've had an MSE type 2. That's it.
Oh, MSE. Okay. Because you were mentioning something about surgery. So I thought it was jaw surgery.
I was considering a jaw surgery.
Oh, you were considering a jaw surgery.
Yeah.
But let's take a look at you. Your angle of the jaw to the joint. You have a proper angle of the jaw with inferior border. Okay. Okay. So that is, why don't we do this? Why don't we actually share a case that we can look at?
Yeah, please, by all means.
Okay.
You're going to jump into a screen share, Doc?
Yeah, correct. I just want to bring something.
Take your time.
The case up so we can do that. Would you want me to go through some revision cases?
Yeah, why don't I think this is a great time to transition from you telling us about joint replacement to you showing us what's actually involved, because just from a boots on the ground, what this surgery actually looks like perspective, I have no idea, and I don't think my audience knows much either.
So, why don't we show the cases? Then we're going to talk about the longevity of the case and the complications.
I would also love for you to just tell us where the incisions are made, where the cuts are made.
I'm going to show you.
And then stupid questions like, is the brain exposed, or how do you separate the mouth from the joint? And do you do the lower jaw on the same day, or is that a different day?
No, it's all the same day. Everything is the same day.
Okay.
And, so
explain it to us like we're fourth graders.
No problem. We have that. So this is a recent case that we did. This patient had 2 double jaw surgeries, and now she's in obviously a 3rd round of orthodontics and the total joint upper jaw surgery. As you can see, the lips are apart for the patient. The bite is apart. And this is after 2 double jaw surgeries.
Come on.
You can see the number of screws that the patient has in the upper jaw. It happens. I'm not whatsoever blaming the surgeon, because the surgeon made certain decisions in his own mind. So I don't know what was going on in his thought process. But for me, this would have been a very clear situation from the beginning. And you can, on the left side, what you can see, you have broken down bone. It's bone on bone.
Show us, doctor, with your scroller.
Yes.
Where you're looking.
I don't think it's allowing me to scroll, but under,
that's much better.
Does that work?
Yes.
Okay. So you can see the condylar head here, and this is the housing. Okay. And this bone,
doctor, maybe just step back and tell us a little bit about joint anatomy. There's a condyle, there's a fossa, and then there's a disc. And remember, we're fourth graders here, basically.
Not a problem. So our joint is made of three components. Okay, one is the fossa, which is the housing of the joint,
the socket, so to speak.
The socket. In between, there's a disc, and this is a condyle. Okay, and the condyle functions with a disc protecting it. And that usually is supposed to be about 2 to 3 millimeters of space between the condyle and the housing. And here there is none. And also the condyle is supposed to be nice and round and bulbous, but this is a flattened condyle, broken down condyle. It's a severe arthritic condyle.
And what's the texture of the disc, and what's the function of the disc?
Yeah.
What does that thing actually look like, and how does it relate to popping and clicking that some patients have? The disc has always been so mysterious to me.
Yes, and we can talk about that when we talk about Wilks classification, which I think would be an important thing to talk about. That has to do with disc displacement. So the disc is as very much avascular for the most part, not as vascular as the retrodiscal tissue or the tendons that are attached to it. And it's white, it's thick, it's very strong, as a matter of fact. Cutting through a disc, as I've cut through many discs, that are even broken down discs, have a really tough texture to it. And if the tendons that are around the disc are not strong enough to hold it in place, then the disc displaces. And then there are multiple different staging that can happen along the way. One would be that the disc in its housing could be displaced forward. And when you open the jaw, it clicks back. And you hear that click, okay, and pop. And then there's early disc displacement, disc recapture, disc going back, and there's late. That's Wilks 1 and 2. Now, then you have Wilks 3, which is anterior displacement of a disc without reduction. That means the disc is forward. No longer you're hearing any clicking and popping. And that's what we hear often after third molar extractions. It happens to a lot of patients who are in that middle ground, or also double jaw surgeries, that if there's disc displacement and now the disc is just staying forward without reducing.
Do you have images of some of these different places that the disc can go to in diseased conditions?
I tried to find out for us.
Yeah, that's okay. We can, if we run into it, you can show us. But basically, the disc is it like a hard rubber with a little bit of a bony consistency, or is it?
I wouldn't say bony consistency, a very hard rubber. That would be a really good way of putting it. That when you're actually cutting through it, you hear the crackling of the tissue, and that's a protector of the condyle. Okay, and as I mentioned, in this patient, the patient didn't have the proper condyles, and breakdown happened, and that's the reason why. Hence, the reason why the anterior open bite happened. And you see the plethora of the hardware that's present there from 2 double jaw surgeries, and the patient still wound up with anterior open bite. That's because the root cause of the problem was not addressed. Has nothing to do with the fixation. Actually, as a matter of fact, the patient was over fixated. That position was not going to change. I'm not a fan of bicortical screws. I do, basically what I do is, plating, and that's a whole topical conversation of itself. But, here, bicortical screws we use. I don't think that was the cause of the, breakdown of the condyle. We just had a condyle was broken down.
What does that mean, bicortical, doctor? Tell us what that means, please.
So bicortical is that the screws that you see, right in the body ramus area. So, those screws going from outside the bone towards the inside. So they are engaging the whole width of the osteotomy from outside to inside. Oh, right. So that's called bicortical, from outer cortex to the inner cortex.
So it's screws that actually connect the proximal segment and then the other segment, and they span the void that's between them?
Correct. That basically the proximal segment and the distal segment, the condylar bearing and the tooth bearing. And as you can see, for these patients, for this patient here, for example, this patient's only hitting on the third molars here.
Doctor, could you leave presentation mode so that we can see your scroller?
Sure. Absolutely.
Yeah, that's much better.
Here is the only area the patient is hitting. Even if you take out the third molars, which this patient had premolar extractions, by the way, even if you take out the third molars, ultimately the second molars are going to hit, but you're still not going to have any contact. So the share is not loaded. The load is not shared, amongst all the dentition. It's only the back teeth that pay the price. Ultimately, periodontal issues, breakdown of those teeth, the pain of the joint was heavy. Even here, you can see that the condyle is the housing of the condyle. This would be the external auditory canal. Okay. The ear would be, and the condyle is forward and it's arthritic in that fashion, in the surface of it. It's supposed to be nice, rounded and bulbous, and it's not here. Okay.
So when you refer to the root cause in a patient like this, doctor, just help me understand. The root cause here is that there's this arthritic condition in this joint. And essentially what happens is that the bone, it withers away. And so that it changes shape and it withers away like a piece of chalk after you use it for so many weeks. It becomes just a little nub.
So let's put it this way. I've taken out a lot of these bones, right? Actually, we recycle this bone. We graft the upper jaw with that bone that we take out from the condyle.
Wow.
So when we take that bone out, I have awesome autogenous bone, which is gold standard. So graft the upper jaw surgery, Lefort 1, I graft the Lefort 1 with that, especially between the segments and the area of the osteotomy. So,
but is that risky if the bone is diseased?
You know what? That's a great question. And no, I wouldn't say it's not risky, because when you take the bone out, all it's going to be behaving as is a scaffold, Ron. Okay. It's basically with the process of what's called creeping substitution, the body little by little eats away at that bone and lays new healthy bone.
Okay. And do you process that bone by putting it into some kind of grinder?
I can show you. I do not do that. I actually use the block to stabilize to the maxilla.
Oh, wow.
Which I think I might have an image for that I can show you here. If you look at this as a chapter that I published for, combined temporomandibular joint replacement and orthognathic surgery. And you can see that here was the osteotomy site. This is segmental procedure, by the way. Segmented the upper jaw with the piezo and expanded it, put the palatal splint in, put the patient in the final bites. And it's a total joint upper jaw case, by the way. This was from long ago. This was my stock plating that you can see so nicely is bent to where it needs to be. And this is the blocks of bone that I screwed to this gap for the proper healing of the segments.
Oh, wow. That's a pretty big void that you filled with that.
Yes.
That's what, 6-7 millimeters of gap there?
That it has about 6-7 millimeters around. So if I was to imagine, what that would be.
Wow.
And some are a bit more than that. So we do with these big movements. This is the best way to go about it.
And how do you fix that bone in place? You just put another screw in it?
Screws. Yeah. You can see the screws. The difference between what we have here and what we otherwise would have here, this is a much stronger maxilla. So at one point, if you have to take the plates out, guess what? Everything is together. And the gap between the segments, that has been grafted as well.
So you put this scaffolding in, and then you also graft with additional, probably more powdery materials to fill in the voids?
You don't need to. In this situation, you don't need to. Because you're going from the piriform all the way to the ramus. I don't have to put the putty bone. This, as I said, I have gold standard bone. Why would I want to use putty?
That's incredible.
That's why this takes longer. When I was telling you the difference between IKEA furniture versus Italian furniture, this to me is Italian furniture.
And how do you cut it to shape? Is that just something you do manually?
Hands.
Wow. Do you just do you put it on the table and you take a piezo knife and you carve it up?
No, it takes a saw actually for this one. I clamp it together with a saw. It's a bit of carpentry, whatever you want to call it.
Sure.
But it's what you have to develop as far as the skill to be able to do that.
That's incredible. And
so that's why this takes a bit longer. That's the reason why these cases take a little bit longer. But we're setting this case up for success for the long run.
Doc, when some people say that grafting often isn't even done with a double jaw surgery, what does that mean? Does that mean they'll create a void between the maxilla and the cranium after the advancement, and then they'll just leave it blank?
Well, mainly what orthodontic surgeons want is to make sure they have some sort of contact at the piriform and the zygomatic buttress, which is here. So the pillars of the face would be 1, 2, 3, 4. If you have stability in those areas, you're fine for the most part. But I can't leave it to that. In my practice, I want to give the best to the patient, and the only way really to do that, to make sure that this gap is filled, is with bone. And I don't want to leave that gap for them, because over time, this bone will remodel and become very much anatomical to the area, because the muscle, fascia, everything will form it. But yeah, I do my best not to leave many gaps behind. I like to get this wall to be nicely grafted.
And you get good results from this type of autogenous grafting?
Yes, 100%. I think that, to me, it's the best way of doing it. Some cases you don't have access to the condyle, obviously. Sometimes you might have to use the anterior iliac crest. It's rare for us to do that. But some of the major asymmetry cases that we've done, that we've taken bone from iliac crest, as a matter of fact, we had a protocol for this for one of our syndromic patients that we did. And the patient had a condition called Goldenhar syndrome. And it's a much more aggressive hemifacial microsomia, basically form of deformity. It's congenital. So I can show you what we did for that patient. We published this in American Journal of Orthodontics. So as you can see, this patient is asymmetric. Okay.
Born this way, doc, or is this something
born this way? Born this way. Amazing patient. I had really the opportunity to work with, and this was a very involved surgery. So the inferior border of her jaw was not symmetric on two sides. So we did peak implant to make the two sides equal. So when we take care of the asymmetry, we can go ahead and make sure that, the inferior border is together. As you can see, the gap above the blue segment on the right side, that's a big gap.
Massive.
So, and the patient, as you can see on the right side, doesn't have a joint. There's a broken down joint on the left side. So this was the planning. And where you see the blue that's in the gap right now, and if I was to show you what we have here, that blue segment is what we virtually plan to get from the iliac crest. Okay.
Wow.
So we fitted that gap with a custom plating. This case is from 2018. So with custom plating, and also with
peak implant.
The peak implant, to be able to make sure that the zygomas are basically equal on two sides. Okay.
Did Giant design that one for you, doc?
This was KLS.
Oh, okay. Yeah.
Yeah.
It was
KLS, the plating actually was, in this case, was Stryker, and this was KLS Martin. The joints were Concepts at the time. They didn't buy that yet. But we had guides to tell us exactly how much bone we needed to fit that gap. So autogenous bone, the best bone. Now I know with 18 millimeters, that we have to do a cant correction, that this is going to stay stable. And
do you go into the pelvis to take this? For anyone who's listening, not watching, although if you are listening, I would encourage you to also watch. This has been a very visual presentation for the past 15 minutes. Dr. Movahed is talking about taking bone from this patient's, would you call it the pelvis or the hip?
Iliac crest, hip, anterior iliac crest.
And then placing it in the patient's face in order to fill a massive gap as part of the surgery. Doc, are you going into the patient's hip yourself?
Yes. In this case, we did. Sometimes I need a tricortical bone, which is, through and through. Sometimes I have someone else get the bone for me, but in this case, we did ourselves. It's anterior iliac crest, very easy to access, plethora of amazing bone, and we were able to, reconstruct that for the patient. And this patient had previous procedures also. For example, you were asking about incisions. The incision that you see here and here was a distractor that was used for the patient. Our incision is behind. And for this patient, didn't have an ear on the right side. So the incision was back here in the hair to get to the joint.
I'm sorry, she didn't have an ear on the right side, Doc?
No, this is not a real ear.
Oh, God bless this girl, huh? She's been through it.
Oh, she is a tough young lady. And this is an incision that you can see right there. And as I said, this is not an ear. So we went from a retroauricular approach. You can imagine how much more complicated these cases get because of that. So we were able to transform her face and give it a better quality of life, bite and everything. And it's a prosthetic joint. Inferior border is matching because you can't see the peak implant and the inferior border. We did this in 2 phases. And this is our 2-year retention and profile front. The cant is taken care of. This is a heavy cant. You can't do this without joints. You can't do this without, otherwise without using the autogenous bone that the patient had.
No, you certainly can't. And how did this girl's life change?
Just think about the fact, what you have to deal with a face that's sideways. To me, she was a very, strong, confident young lady that even if she didn't have the surgery, she would have been fine in her vision of herself, which I'm so thankful to have been a part of her care. But to be able to function open normally like the rest of us, up and down, not to the side.
Chew and eat. And
the airway being better, the facial profile being better.
Did her speech change? I can imagine that there was probably some kind of speech difficulty initially, right?
No, not really.
Oh.
She actually, I would say for the most part, speech, everything was together for her. She adapted very well. Us humans are amazing in the fact that we're able to do that. Right?
Yes.
We were able to adapt to many anatomical deformities that we have. And it's not till you're at the place that you're on the end of the road and things are fixed that you're going to be able to really appreciate what's taking place or what was possible. A lot of patients sometimes don't know what is possible.
Well, I think a lot of jaw surgeons probably don't even know what's possible if they're looking at a case like this, because you're doing things I've never seen anyone else talk about.
That's the reason why a jaw surgeon that does this has to understand these procedures in a comprehensive fashion. You can't just be a one-trick pony.
Right.
You have to have multiple tools in your toolbox to be able to properly triage the patient and select the right procedure for the right patient.
Yeah, I think this weird thing happens in everything in life, but especially in medicine, where if it's not something you do, if it's a tool that's not in your arsenal, then you just have a blind spot for it. And you have this whole kind of operating system that's built around just operating around these problems, because you just can't do it. It's just a major blind spot.
I mean, for example, in the world of plastic surgery, a deep plane facelift is superior to a normal facelift, the one that doesn't involve the SMOS layer. The deep plane facelifts look beautiful. They're lasting. They look rejuvenating and natural, but the superficial ones do not last. And someone that's done a superficial one all along are not going to dare to do a deep plane facelift because they're not trained in it.
So what's the difference between those two, from a perspective of actually doing it mechanically? How is it different?
So the SMOS layer, which the facial nerve is involved in, that is also placated back with a deep plane facelift, while with a more superficial one, it's just a superficial layer of the soft tissue. It's a lot easier. And one takes about, hour and a half to 2 hours. The other one takes 5 to 6 hours to do. So, but the results are just, you can deny the results. Dr. Nayak is right down the street from us, who's one of the, along with Dr. Ventali, they're the 2 best facelifters in the country and the top 5 in the world. And that's all major part of what they do in their practice is deep plane facelift.
How rare is that compared to the normal type of facelift?
It's not that rare now because initially it was these, 5-6 years ago, they did more of that, but so it's not as rare. But the people who have done more of it are the people that are going to be better at it, obviously.
Speaking of cosmetic enhancement, while we're on the subject of peak implants, which you just showed some in that case, do you use peak implants for purely cosmetic purposes, like to do malar implant, infraorbital implant work, or even supraorbital implant work as part of a jaw surgery?
I've done that for some cosmetic cases that patients want the cheekbone to be strong. It's just more than anything else, harmonizing the face. But in this case, as you saw, that is more of a, let's just say that's more of a, functional, not functional, it's symmetry because of the bone was not developed on one side. So we wanted to create the symmetry. The inferior border of our jaw on one side was way smaller because the bone also was not formed on one side. So that's how we were able to, make the two sides symmetric.
What's your opinion on implants to harmonize the face as part of jaw surgery? Is it something you do often? Dr. Gunson told me he does it quite a bit. I think he said in 3/4 of cases, he's doing some kind of malar implant. And if so, what type of implants do you like? Do you like the PEEK?
Oh, the PEEK is the best implant. It's costly, but it's the best implant. If I'm to choose, I would go with a PEEK implant. It has a chance of infection with that is lower. KLS Martin is the only company that has it approved for the mandibular, for the mandible. Synthes also has them, as well as Stryker, but they're not approved for the lower jaw. But it is the best implant. I don't like the implants that float. I like the implants that are fixated. The chance of infection is lowest, and that is PEEK. I mean, there is no way around that. Yeah.
And you have so much attention that you pay to using autogenous materials. Like you mentioned using fat as part of a joint replacement. You mentioned recycling the excised condyle, in order to use it in the maxillary grafting as part of the Wolford. You like autogenous materials, and yet I'm also hearing you say that, you like prosthetic TMJs and that you like PEEK implants. So how do you sort of square that circle of autogenous versus exogenous materials?
Sure. I mean, for a cheek implant, you're not functioning on, right? The inferior border augmentation, it's rare. I don't do it too often, but it's only when it's needed. I can augment the inferior border with basically bone graft as well. I can show you an image of inferior border that was augmented with other than for example, an implant. It does not look good at all.
What is the inferior border?
Inferior border of jaw would be right here.
Oh, okay. So sort of like the ramus area, like a ramus implant?
Yes. It would be like the ramus. I'll show you right now what, for example, here, I just want to make sure that I keep the patient's name out, but this grafting here, to me, is not elegant whatsoever.
What is
create
that?
the inferior border. That's bone graft. For this patient had bone graft done. And to me, that's not an elegant way of doing it. So in a case like this, as you can see, the ramus height is smaller, right? I would not have used this if I want to get a nice ramus height and inferior border. I would have done a PEEK implant in this area. And that's extra added. But the thing is that to begin with, it's a broken down joint. That's the reason why the height of the ramus is shorter. Okay.
Yeah, so this whole thing is kind of a Band-Aid job.
It's, listen, if it works for someone, I have nothing against it. But in my practice, I'm not happy with this shape. Yeah. I want a nice angle of the jaw or the patient's actual angle of the jaw to be brought in the right place. And if the syndromic case that we discussed before, that is basically not possible, then it's PEEK implant. No, it's just got to fit the bill in every way possible. So this actually really, I think it makes the point here. This patient had 2 double jaw surgeries that failed. You can see the lips are apart. Okay. And the chin to neck length is back.
What's going on with the lip stock? Tell me about lip incompetence and what you see when you see that.
Okay.
Lips are complicated. I don't think people understand them and realize what an important role they play in jaw surgery.
For me, lip competence is extremely important. I don't think a single person out there can read, Nestor's book, Breath, and not really want to make sure that surgically to provide that for their patients.
How do you provide that surgically? What's the foundation of the lips? The
foundation of that is the occlusal plane, is the lower third height of the jaw. So if you get the thirds of the face equal, okay, and you really take care of the occlusal plane, bring the angle down and forward, that brings the lips together. And
like you're describing like a rotation, a counterclockwise rotation?
counterclockwise rotation, plays a major role in that. But part of it is also the patient too. The Buteyko breathing, techniques, exercises. That is so important. I'm rereading actually, Nestor's book because there's so much awesome stuff as a journalist. He really packed in there, but it requires a second reading if you really want to get into the detail of it. But we knew a lot of that from that nasal obstruction results in facial deformation, for example, from the Harvard studies and the primates. But so I want to make sure that I give that to my patients.
Yeah.
To me, it's extremely important. It's not just do the surgery and you're done, but our patients have a physical therapist. Our patients have, SLP Mayo. I have SLP Mayo in our office. Irina Schwartz, she's amazing. That is, I think that is extremely important to be part of the armamentarium they use to improve these patients' ability to breathe, the tongue posture, and also provide adequate housing for the tongue.
So you very much take a more holistic approach to fixing these craniofacial, airway, myofunctional issues?
100%. That's the reason why the lecture that I had about a year ago, World Dental Sleep Society, my talk was the multidimensional approach to airway. It's not just the AP. It's the widening of the upper jaw and lower jaw really needs to be paid attention to. And that's the reason why majority of our cases are segmental. Some have MARPs before. We want to gain the maximum, but also while not hurting the patient. I'm sure we're going to get to that, but I just kind of wanted to go over this and show you this.
Yeah.
Because
I definitely want to talk to you about segmental and why it's such a rare thing in the OMFS space. And, what percentage of your cases get that and why it's so important. Segmental is a hot topic. And then obviously how segmental relates to MARPI and what segmental can do that MARPI can't and what MARPI can do that segmental can't.
Sure. No problem. We'll absolutely go through that.
Sure.
That's going to be the whole talk about MME, followed by MMA, or what is possible when it's needed. Both of them together is amazing. Actually, just today I had a patient who stopped by is a class 3 patient that the transverse width discrepancy was 18 millimeters. So we got 12 millimeters of it with MARPI and the other 6 millimeters with segmental osteotomy. And a lot of orthodontic surgeons are not comfortable because they're not getting stable outcomes with segmental. And it's scary to put the least, but about 90 somewhat percentage of what we do is segmental.
Wow.
That's, and where we're talking about the joints, Ron, so I just don't want to get off topic on this one. Take a look at these joints here. So remember we were talking about the housing that's here. And if you take a look at the condyle here, this is a broken down condyle and small. But this is the condyle after 2 double jaw surgeries. Okay. This patient had 2 double jaw surgeries and the joint was broken down. This should have been a total joint upper jaw from the beginning. And every single time for them to close the anterior open bite that was happening, they wound up posteriorly impact the upper jaw instead of doing counterclockwise rotation, opposite of counterclockwise rotation. Okay. And every single time they did posterior impaction, that means the lower jaw kept going backwards. And what did they have to do? Do a bigger genioplasty, which looks awful. While all along the way, the ramus height was just decreasing because the joint was breaking down. Okay. And what the point I wanted to make to you about the ramus height, which is so important, the best, most holistic way of getting the actual patient anatomy to where it belongs, where it should be, we're reversing the effects of condylar resorption, is to do the counterclockwise rotation with a prosthetic joint. Okay.
Right. Because otherwise you can't make up that height.
You either have to do the grafting or you have to do a PEEK implant or such. You can do that, but it's not the patient's joints.
Right.
Sorry, patient's bone. This is the actual patient anatomy. So you're actually bringing the angle to where it's supposed to be without any deformity around it. If you have a patient who's thin and, for example, you wind up doing cuts around there to make up for that, it would be so noticeable. So I really like to have no cuts in the mandible for a case that we're going to do a total joint. That's the reason why the revision case is a lot harder because you're never going to achieve the same outcome if you have done the double jaw surgery first.
Time out, doc. So you're saying on the lower jaw, when you're doing a joint replacement, there's no sagittal cut, there's no BSSO. The movement of the mandible is all happening
from the back.
Oh, that's wild.
Splits.
That's crazy.
The source of the problem. That's why this is so powerful, Ron. It is one of the best gifts that has been given to our specialty. And so when you realize,
it's more invasive in a way, but it's also less invasive in a way because you're getting away from the sagittal cut. And isn't the sagittal cut a lot of where the nerve damage happens?
Exactly. Nerve damage for inferior alveolar nerve is very low for this in comparison to a double jaw surgery. But we also don't forget it. For example, for these patients, our movements are pretty big. They're large movements. Are we going to come across the case, hopefully we have time, that we moved the lower jaw 34 millimeters in a pagonion.
That's the most I've ever heard. I've heard of 3 centimeters. I've never heard of 3.4.
Yeah, 3.4. It's a syndromic case, but 29 to 30 is average for us. And we can do it with confidence that it's not going to relapse. Okay. So this is a patient post-surgery. The chin was still not in a good position. So that was taken care of afterwards. You can see the chin to neck length is better. Lips are together. Patient had basically some implants in the lip.
Oh, she looks great. What's the chin to neck length? I've never heard of that metric.
Chin to would be from pagonion to neck.
Okay.
Just this area right here.
Oh, okay. Got it.
So as you can see the video of the patient, a patient had a lip lift done as well, but that angle would be impossible to have done. And the third double jaw surgery would have been the definition of madness. Okay.
Sure.
And this is actually, we already went over that case. So I just wanted to show you after the incision that you see, this is 3 months out. Okay. At the neck. Within 8 months to a year, you will not see that.
So that's where the incision is made for joint replacement. It's made in the neck.
Yes, it's made in the neck, and also an endoral incision, which is this behind the tragus, very small. No one would ever see that.
And then
I've had one.
Why the 2 incisions? How do you then work with those 2 incisions?
Okay, let's see. This is the bite for this patient, but I'm going to get to a video that shows how this procedure is done. Okay, and that's, by the way, that's the bite before. After 2 double jaw surgeries, now the joint upper jaw. So that hurts me to see that much hardware there and 2 surgeries that the patient went through when they could have had the total joint upper jaw from the beginning in one procedure and everything would have been taken care of.
Yeah. What's that in her neck on her spinal cord?
That is actually her earring. So.
Oh,
Good pickup. Really good pickup.
I mean, you never know, man.
Yeah, I agree.
You never know. And when I'm interviewing, the stuff I see is going to be pretty gnarly. But pretty earrings, though. They look nice on a scan.
They did. It sure did. Let me see. I'm going to show you. Actually, you know what? Along the way, this would be a good way of looking at this. So if you look at this patient who has ICR, and this is where the whole talk about the angle would come through. She's at this point 2 years out.
Okay. ICR, doc, if you could just remind us for people that are tuning in late.
Absolutely. Idiopathic condylar resorption. And this is a breakdown of a joint with anterior open bite, high occlusal plane, high IMPA, which would be procline lower incisors, because as you can see, the lower jaw is receding and you can see the lips are apart, and after surgery, they're together. Okay. That's a lip competence that we want to get to. This patient was dealing with a lot of pain, constant pain associated with a joint. And she was one of the most amazing patients to deal with. And her parents were wonderful. They did their homework. They did their research. And you barely, at this point, she's a year out, you barely can see the incisions in the neck or ear.
Yeah.
Okay.
She got the hookup, doc.
What was that?
She got the hookup. She looks great.
Thank you. But this is a patient the day after surgery. Okay.
How long after surgery were you? Surgery. We know when it's not going to be here. We're just going to take a shot of the side. Like this.
She doesn't even look bad at all the day after surgery.
I'll show you another one as well. But as you can see, the joint here was breaking down. Okay. And occlusal plane is high. We counterclockwise rotated her. That's a segmental 3-piece. Okay. I work with Dr. Moshiri on this case, who's an amazing orthodontist. I'm very thankful to have the opportunity to work with him because he really makes magic happen with the bites. And he is so detailed that almost all the cases that we do together has to be segmental because he wants everything uprighted in a proper position and angulation of the incisors in the right place. It's truly a honor to work with him.
Tell me about the importance of the relationship between orthodontist and surgeon when planning a case that's complicated and complex like this. Like, I think a lot of people neglect the role of the orthodontist in the communication between orthodontist and surgeon when it comes to a jaw surgery. Yeah. What's that relationship like with you and Dr. Moshiri?
It is a important relationship, which is a relationship I have with Dr. Moshiri and Dr. Mandibular. For example, I would work a lot with Dr. Ferrari as well in California. And Dr. Nuez. So these are the people that I get to work with and there are many other orthodontists as well. But, these are people that I get to work with that we see eye to eye from every aspect, from the aesthetic of the bite, from the setup, make sure the teeth are uprighted properly on the basal bone so I can do a segmental, get everything in the right place. Preparation for a segmental surgery. Not every orthodontist knows how to do that properly, to diverge the roots between the lateral incisor and canine, to open the way, it's called Iowa spaces or distal lateral spaces, which would be here. Okay.
It's room for you to cut without hitting the tooth nerves, right? Or the tooth roots?
Yeah, exactly. Tooth roots. I've hit 2 in my career, and there were cases we predicted that to happen. But Ron, as you can see, that's how we are able to segment the upper jaw in 3 pieces and uprighting these segments to make sure they're awesome and nicely parallel. The lower teeth are nicely uprighted on the basal bone. And if there's not enough bone, we ask Dr. Mandibularis to lay bone for us to make sure that in the long term, longevity of the periodontium is in a great place on the teeth. And Dr. Moshiri, we do a lot of Invisalign cases. As a matter of fact, there are things that we can do with Invisalign that is not possible to do with traditional braces. So he's mastered that art. Actually, he wrote a consensus paper as far as orthosurgical cases are concerned. But he was very well known just in the world of Invisalign before. Then he took on the tough job of doing surgery, 3-piece with these cases. And that was years ago that we did. 10 years ago, we started doing the segmentals, and we really have it down to a science at this point.
So in terms of orthodontically prepping a case, Doc, like you mentioned getting the angulation of the teeth right, and you mentioned upright. I noticed you didn't mention like having them slightly tipped lingually. I think some people
buccally, a lot of people wind up, because they do a lot of expansion in the upper jaw, then you have to upright the lower teeth. They have to tip it out. And that's a whole other conversation of its own. So that's a problem. But if the teeth are lingual, in order to make more room for the tongue, you want to make sure they're straight on the basal bone, the bone that's the mandibular bone underneath it.
Is that the natural orientation of teeth? Is more upright rather than lingually tipped a little bit?
Yeah, because we have a lot of underdeveloped maxillas. That the teeth follow teeth, and the lower teeth go lingually. And so orthodontics will help us upright it on the basal bone. And as long as you upright it on the basal bone, the chance of relapse is minimal. But obviously, proper orthodontics needs to be done to make sure you have stable outcome for the long run. We might be looking at our 12-year-old cases, and the bites are dead on, So that's what it is, finishing the case. Right. Setting it up for success, finishing it. I was just on 3D systems. I plan with Synthes and 3D systems. And I have my favorite of each that I take. For example, there's a whole nother conversation of its own. But one of the things that with the engineer we were talking about is that, hey, the cases from those orthodontists that you work so heavily with hand to hand and they care about their craft, those cases are so much easier to finish or set up for surgery because everything is lined up right. You have a reproducible bite. My tough job for me is to do the segmental and getting everything together, but
So
it makes a difference.
you like the patient to leave the operatory with a functioning bite already. You don't like to rely on too much post-surgical orthodontics.
No, post-surgical orthodontics, no matter what, especially with multi-piece maxillas, it is a must. I mean, we have finished cases as short as 5 to 6 months, as long as 2 years after. Every case is different. But the most important part is that to take advantage of the RAP phenomena, which is the rapid acceleratory phenomena post-surgery, to move these teeth fast and get them to where they're supposed to be. But the upper jaw movement of teeth cannot happen till the palatal splint is out, which is the splint that I showed you that maintains the width of the upper jaw.
And how long does that take?
Anyone who does 3 months.
Okay. Is the RAP still occurring after 3 months?
4 to 5 months is when the RAP is at its highest.
Yeah. And then you can always bring Dr. Mandibularis in to initiate a new round of RAP, right?
If need be. But I mean, like most of the cases, when he does that ahead of time, he puts such massive amount of bone, lays massive amount of bone down that those are some of the most awesome cases. We just had a case recently that Dr. Mandibularis did the SFOT, and Dr. Moshiri did the Invisalign orthodontics portion of it. And normally this case would have been ready for surgery for about 8 months. And he was able to get it ready for surgery in 3 months.
Come on.
3 months, no joke. Wow. And at one point, I'm sure you're going to have Dr. Moshiri on, and he can explain that to you, and how it was done. But it was impressive, Ron.
Well, yeah. And do you think that bringing in someone like Dr. Mandibularis to facilitate tooth movement after surgery, can that help counteract some of the relapse that post-surgical orthodontics can cause? And maybe correct me if I'm wrong, maybe it doesn't cause this, but I've been told that doing lots of orthodontics on the upper after segmental can lead to relapse because the site is so fresh and there's lots of, voids in the bone, and it's just not advisable. What are your thoughts on that?
Not true at all. We've done studies on our segmental cases at St. Louis University, which is, by the way, the birthplace of orthodontics. And this is highly detailed studies. We're about to publish it at AJO, American Journal of Orthodontics, which has a high impact factor, and it's very hard. You not just put your opinion and everything flies. There are multiple people that revise every bit of the manuscript that you sent in. So, very much scrutinized, neutral, in every way possible. We studied our segmental pieces. As long as the palatal splint is in place for 3 months and, everything is grafted nicely, my God, stability. We have not lost any width in those cases. If anything, some of them were able to expand a bit more. The 18% relapse that we had was to close the movements that required to close the gaps for segmental.
Right.
That's it.
Right.
So if you do these right, and this is all the misconceptions out there, segmental is a very powerful technique to upright the segments. And this is Dr. Gunson says that actually the flowering, the blossoming of the segments.
What does that refer to? Going like this?
So actually, let's go back to this. For example, these segments that you see here, for this to be uprighted to the sides to make sure they're parallel with the lower teeth, that's uprighting it. We want the buccal aspect of the incisors to be parallel to the true vertical line for the best aesthetic outcome. And when we do a counterclockwise rotation, the angulation of that incisor changes. That means sometimes if you want to get the right angulation, literally the roots will come out of the bone. But that yellow segment, we can rotate it to get the proper angulation of the incisor, hence the better aesthetics. Okay. And, for example, in this case, as you can see here, this is what the patient sent to me. It's like, Dr. Movahed, I noticed something that I didn't realize that I didn't have. And my jaw actually has an angle. Okay.
This is a total joint replacement?
Total joint upper jaw. Yeah.
Yeah.
You can see on the left side, that angle is all the way in the neck. And if you go back and look at where the angle of the jaw was before, it's high up there, right? We are able to bring that down in the right position that the patient was supposed to be.
Powerful.
Okay. That is impossible to do with a double jaw. You got to either do peak or do the bone grafting that I showed you, which I'm not a fan of. To me, it's not pretty at all. I mean, you can't even look at it in the same fashion as this. This, for a patient that has joint resorption, this is the best way to go about basically getting everything to where it's aesthetic, the bite is together, the lips are together, and airway is improved.
She's happy.
You can just read her own words. You know, as you can see, 47 millimeter opening. That is ginormous. You can see it with the orthodontics where Dr. Moshiri got everything too in terms of the bite. It's a gorgeous bite. She mentions everything as far as difficulty breathing, live in constant pain, self-confidence, everything.
What's the significance of the range of motion metric, Doc? Do some people criticize that total joint replacement means you can't like open your mouth as much anymore? And this is to show that yes, you can. Misconception. Okay. These are absolutely, in a way, I would say, lies that folks, tell out there to make the case for the one procedure that they do. All of our patients are over 35. Most are over 40. And you can see in this case, 47 millimeters. What's normal?
Over 35.
Reference? Over 35 is normal?
Yeah.
Oh, so this
Under
is
30 is trismus and over 35 is normal. Yeah. So you need over 35 to function, but we're not happy with just 35. Our patients are all in the high 30s and low 40s on average. And this patient is 47. Okay. I mean, so this is actually, I think answer your question very nicely. This is a transformation that takes place on the table. You can see how the patient is, basically prepped for surgery. And the same day, the lower jaw comes forward with the total joint. Okay. And the upper jaw comes forward as well. And there's no cuts with the bone inside. So this is the patient 2 days after surgery.
Damn, he looks good. Yeah, I'm not actually getting the audio, I don't think, but that's okay. I still like seeing the patient and the dynamic.
Oh, okay.
Yeah, so but I still like the video though, because you can see what he really looks like.
It's saying it has a 2 out of 10 pain. And this is where he started. On day 2 out of 10 pain with total joint upper jaw surgery. And you can see orthognathic in the upper jaw, lower jaw. Lips are not together. Okay. The movement, as you can see, 3 centimeters in the lower jaw. It's an average for us. About 10 in the midline of our upper incisor. And we had to kind of get the chin impacted a bit to get the thirds of the face, equal. And you can see the joint is very broken down. That's
a crazy angle. That downward slope is crazy.
Do a double jaw in this case, and let's see where the angle is going to be. Okay? Impossible.
Yeah,
and
this needs
you
a
can
joint.
see the condyle is anterior to the fossa. It's not even in the fossa. So to show you, this is where the condyle belongs, and the condyle is forward. And if in my practice, this is not okay to do a double jaw in a case like this. If you want to do a counterclockwise rotation, the proximal segment would be down here. And even if you want to do a reverse L, it would be a terrible looking bite.
What is a reverse L? I've seen it. I've heard it mentioned, but when is that used? And tell me about the reverse L, Doc.
I don't do it because whenever a reverse L is necessary, to me, that's a total joint. And it is not a treatment for that is going to benefit anything for the condyle. I mean, so mentioning to you. Go ahead.
A reverse L is like a cope for what should actually be a joint replacement, basically.
I wouldn't even say that. It's just another way of moving the lower jaw down and forward.
But idea is to create more of a gonial angle? Is that the idea?
Actually, it's not the gonial angle that comes down. You make the cut here, so this part comes down. Then you have to graft the rest of it. But again, it's not going to look as natural as this. Would you rather have this, or would you have cut portion of this is going to be down here?
I know, but I'm trying to understand what problem that the inverted L is attempting to solve. Is it attempting to solve this problem?
Yeah, it's certain movements of the jaw. Yeah. I mean, like, this is all things that you can do intraorally to bypass doing the right thing, which is the joints.
Right.
Okay. And this is all just, however you want to put it, a coping mechanism, whatever it would be. To me, it doesn't make sense. When I see what a total joint can do, a counterclockwise rotation from 23 degrees to 9 degrees, good luck with anything else. Custom plating for that patient. Okay. To make sure it's the best bone, and then grafting of those gaps that you can see.
Is that Synthes?
This is actually Stryker, but Synthes actually is my favorite plating custom. In the mandible, I use KLS Martin, the locking screws and plates that I use because those are stock if I'm doing a double jaw. In the upper jaw, for me, I don't think many companies can rival the Synthes product. A bit more expensive, but their product is amazing as far as the plating is concerned.
Yeah, wow.
And the screws for the maxilla works very nicely. So I'm hoping one day we're going to have the locking mechanism in the upper jaw. But to me,
you mean you hope that Synthes integrates the locking TAD mechanism so that the screw screws into the plate?
Sure, exactly. And I think they're working on it, Ron. They're working on it. They really are aware. And, the company is, and most companies are trying to get there because they know the value of it. But it is more important when you do a double jaw surgery in a mandible to use locking screws.
What is the value of it?
Value of it is that, the screw is going to be stabilized to the plate, so it becomes one unit. So if the screw becomes loose along the process of healing, the bacteria can easily basically start growing in between that crevice, and that could cause infection. With a double jaw surgery, we have 3 to 7% chance of infection, and that infection almost 99% of the time happens in the lower jaw. I only had one in the past 10 years. And I give most of the credence to that for that, or the reasoning why we had such low infection rate was because of the fact we were using locking plating in the lower jaw. But Synthes is working on it. I think KLS Martin and Stryker are working on it. It's just very much harder to use the custom plate and, machine in the thread that the screw can go into.
Well, it also would make the plate thicker, at least in the site of the TAD, no, or not really?
Yeah, not really. It's just a matter of the technology and the fact that they have to go through FDA again. FDA is definitely a hindrance for a lot of technology to be available for us.
Right. And does the locking TAD also create less daylight between the lumen of the plate and the screw itself so that you get a smaller tolerance of how much the bone can move after it's plated, or is that a lesser concern?
Yes, actually, you said it so right. The thing is that, if you have a lag screw, and this would be the plate, if you have a lag screw, it will bend the plate to the bone. And over time, that can come out and cause infection. But for a locking plate, the plate will stay where it is. The screw will go in, lock into the plate, and still giving you the stability against the bone without pulling the plate and creating that creating that tension in the plate.
Yeah. It also probably prevents over torquing, right?
Exactly. Absolutely. Yeah. That's why I use the locking in the mandible. To me, in the mandible, locking is king. And I'm very lucky that KLS Martin did make Z and L plating for me. That is my design, and I'm able to use their plating for the mandible. But to me, custom plating wise, maxilla, Synthes, I can't get away from that.
Yeah. And you said that they did it for you, meaning that you and KLS Martin have an integrated relationship where your feedback changes their designs?
They were very kind to do that for me. And that's the plate that I'm still using in the mandible.
That's incredible.
I'm very lucky that they worked with me on that. And it's in 10 years on, I'm still using the same plating.
Wow. Bless you, Doc. Yeah. And we were talking yesterday about the FME, and we'll talk more about expansion later. But one of the big upgraded features of the Facetronics midfacial expander is that it has locking TADs. And I think with MARPIs, probably even more than with surgical plates, that daylight that can exist between the TAD and the lumen of the appliance it can be very bad, because a lot of the problems with the TADs occur in that daylight space. So when you lock the TADs, you just tighten things up significantly.
It's amazing, Ron, that you understand that concept so well. And that's ultimately where it should be going to. Okay. I mean, this gentleman, again, as you saw, what we did for him, you can see the difference in the eyes. You can't deny that. And this is 6 months after surgery. We have the finished, obviously, version of the case. And this is at 6 months, the incisions are barely noticeable. And this is where we have it. Okay. Major advancement of upper jaw, lower jaw. Now this is him at finish, which is, he was finished about 8 months post-surgery.
Wow. Look at that bite.
It's gorgeous.
Midline is dead nuts.
Yeah. So, this is this was done with Invisalign. Okay.
Yeah.
So we need not, bastardize Invisalign for jaw surgery, because if you know how to utilize it, good God. And there was an AJO paper by Dr. Resnick that mentioned that at 2 to 3 weeks post surgery, the swelling is less with Invisalign cases versus braces.
Do you use Invisalign even with segmental? Because I know Dr. Gunson requires braces for segmental.
I like the way that Mike goes about what he does. And I went to Arnett Gunson course when I was a resident. That was, but that's also one part I got to tell you. I don't understand why. I really hope that Mike is going to start going towards the Invisalign side, because there's so many benefits to it. But listen, it works in their hand. He does an amazing job of surgery with his double jaws. Big fan.
From his point of view, why does he feel like he needs a wire to do a segmental? What's that give him?
I think it's just a matter of him being able to control the vectors, elastics, post-surgery, which is very important to us. But we have buttons now that we put on for Invisalign. Post-surgery, we can run everything off the buttons. So hopefully maybe at one of these conversations with Mike, I'm going to be able to convert him. Yeah. But I know he's very steadfast in using braces, but it's so much more comfortable for patients. It's so much easier to clean the patients post-surgery. We see our patients every day for 2 weeks straight in our office post-surgery. We brush their teeth. We change their rubber bands, suction their nose, make sure that medications, everything are together. So we're very tuned into the post-op process. And all the vectors of elastics and such, whatever needs to be done, we address it. I have an amazing team that works with me. I have 2 nurses, 1 NP, and actually one of the nurses to be NP. I have a speech language pathologist and my functional therapist. And it's just an awesome team.
Yeah. At the risk of asking a question that's maybe beneath you, Doc, what do you recommend nutritionally after surgery?
Oh, yeah, it is, Ron. It is not beneath me whatsoever. That's a conversation we routinely have with our patients. 80 to 100 grams of protein intake is our goal. First day post-surgery is about 30 grams of protein and then 300 cc's of water. That's our initial goal, because most of the time the patients are still in pain and discomfort because of intubation. It's a long intubation. And then once we get there, obviously ambulation is important. The 3 to 4 times a day, we get the patients to walk up and down the hall. As I said, we're very in tune with it. The day after, the second day, we go to 50, 500 at least. That's it. Least minimum will be 50 grams of protein and 500 cc's of water, then 770 grams to 80 grams. And once they do that, we're going to get them out of the hospital. But we post-op steroids are very important with us. And IV does it amazing. IV antibiotics post-surgery. We have our own.
Did you say steroids?
Yes.
To reduce swelling?
Oh, absolutely. 100%.
Is that normal? Because I don't know if I've heard that
that's
before.
That's routine in our practice.
Okay. Is that routine across the board for double jaw?
For double jaw and joint surgery, we do.
I mean, in other practices. Is that a standard thing?
I don't know about other practices, to be honest with you. It's not that I live in my own little small world, but it works amazingly.
So do your patients not swell up like balloons?
I mean, you saw the patients, the 2 patients.
Yeah, it didn't look bad. I was wondering how that's possible with the 7-hour surgery.
Yeah, I mean, it is, Ron, as I mentioned, I'm not trying to beat anyone else's time to do the surgery. I'm trying to beat my best outcome, my last best outcome. And also, I'm trying to make sure I take the patient's outcome and recovery into mind. I mean, you saw those patients. They're going back to this gentleman, for example. This is him 2 days after surgery.
Do you credit the fact that he's not swollen? Because they say swelling peaks, between 2 and 4 days. The swelling should be much worse than this at this point. No,
it doesn't get that bad for us. 1 out of every 20, 30 patients, we have a little bit more than swelling that we like to see. It's rare though, but because as I said again, we're between the ice machine, between what we do for the patients and the steroids and the day in, day out care, but surgical technique, basically treat the tissue well and it will treat you awesome back. That's the way to go about it.
So you're delicate in there?
very delicate. I'm watching everyone like a hawk. You can see this patient. It's the day after. I mean, we just took the head wrap off for the patient.
It's like you're making baklava with the phyllo dough.
Oh my God. Yeah. You're getting me hungry.
Wow, Doc. Yeah, that's incredible. Post-surgical steroids as a way of managing inflammation.
I mean, that's to me, that's somewhat routine.
It could be. Maybe I'm ignorant. I don't know. It could be.
But basically,
Doc, you want to end the screen share?
Oh, sure.
Yeah, and then we can go back to it. I'm just seeing an infinite mirror right now.
Stop. There we go.
Yeah, perfect. Yeah. Well, that's incredible. Do you want to tell us a little bit about the history of jaw surgery as you know it? Maybe like the 5-minute version of how did this all start? Were you telling me yesterday that it started in Germany?
I mean, so it is. Wars are terrible, as we all know, but wars are also the engine behind innovations sometimes at desperate times and such. So everything from Civil War. In Civil War, for example, upper jaw was broken, and they used dentists were involved in taking care of a lot of trauma, facial trauma. So stabilizing a broken upper jaw with an orthopedic device, that's supposed to be part of it. Von Langenbach, and it was the year, I'm not exactly sure, it was late 1800s, 1865 or so. He was able to do a, don't quote me on the year, he was able to mobilize part of the maxilla. And then really a lot of this started in Germany. Also, as far as the double jaw surgeries are concerned, sagittal split osteotomy and also Lefort 1 osteotomy. Schuchart is one of the biggest names that ultimately Hugo Obigeser took some of his work and really popularized it for the lower jaw surgery. But the American contribution to upper jaw surgery is Dr. Bell, who passed away about, I believe, eight years ago. So I got a chance to meet him, Bill Bell, and Bill Prophet Bill's Prophet book, but dental facial deformities. That's a very sought after book historically. But he was the person who figured out that how we can detach bony wise the upper jaw from the skull and have a segment of bone that's only attached to the soft tissue and it can survive. But he found out about the vascular, blood supply to it and did the studies on rhesus monkeys. And he found out that descending palatine vessels that come from the top are an important vessel, but if they're cut, it's okay because the ascending pharyngeal vessel can support it. So he really set up the vascular basis for Lefort 1 osteotomy. But prior to that, the name Lefort, René Lefort, was the person that figured out the patterns that the weak points of the jaw, upper jaw breaks maxilla. So he took skulls, everyone knows. There's very little that in publication that we have from him because they did a lot of search to find out the original papers and such. But he took the skulls, cannonballed, dropped them, and found out their multiple pattern. And the pattern that we use, obviously, is the Lefort 1. Lefort 2 would be a Goran triangle that goes here. And Lefort 3 is a total, complete disengagement of the maxilla and upper jaw from skull. And that's done for craniofacial surgery, obviously. But that was the really beginning of it. But it wasn't really till the surgery came to United States and mainly, between, Dr. Bierman in New York, as well as, the heavy lifters at Parkland, where you have R.V. Walker, you have, Ed Ellis, you have, Larry Wolford, Dr. Epker, Dr. Turvey. These guys are the giants of this surgery.
Parkland, where is that?
That's in Dallas, Texas.
Oh, that's okay. So Dallas, Texas is very much an epicenter in the history of jaw surgery.
Absolutely. And I've got to tell you, privilege of my life, my professional life, was to do a fellowship with Dr. Wolford. And, and first when we started in the fellowship, and I was his last fellow, and the fellow after me quit after 3 months.
Come on, really?
He's a hard worker. The man is a machine.
Dr. Wolford,
basically.
you mean?
Dr. Wolford is a pioneer of what I get to do today. Without him, this would not be possible. We owe a major debt of gratitude to this man, because even right now he's going, and I have no clue how he's doing it. His work ethic is like no other. He dedicated his whole life to this surgery. And his happiest place is OR, as most surgeons feel that way. But he has definitely broke the ground for a lot of what we do with joint upper jaw nowadays. But
really,
and initially he was looked upon as somewhat of a pariah, crazy man in the world of oral surgery. But he was right. I mean, he gave us counterclockwise rotation. He perfected total joint upper jaw surgery. We cannot forget about Dr. Moshiri, who is still around, and he's doing research at Rush University. And he placed the first TMJ concepts joint. And he's a scientist of the total joint replacement. Right now, I'm in an orthopedic department at Rush. He's doing mainly just research there. And whenever I need any kind of information for something that is odd, out of ordinary, I pick up the phone and I call that man. And good God, a great source of knowledge.
Wow.
I'm so happy and, again, feel privileged to have access to him as well. We can't forget about the arthroscopy side of it, Dr. Joseph McCain.
What's arthroscopy?
Arthroscopy is using a camera to look in the inner joint space, superior joint space. Dr. McCain is responsible to bring the technology and the way of doing that from Japan to the United States. And these are the pioneers. These are the people that built the blocks that we were able to stand on today.
Is Bill Arnett in that category, or would you say he's a later generation?
I am a fan of Bill Arnett. He's not a fan of joints. I get it. I understand that. But for what he does, Dr. Arnett definitely was able to kind of build some of the language for his course to the layperson understood what was done. But the first counterclockwise rotation was done by Larry Wolford because I saw the slides of what he did. Bill Arnett is a very sensational surgeon, and the way that he looks at face, I'm a fan of. So there's not that much difference, I would say, in a lot of ways between Bill Arnett and Larry Wolford in the way they look at faces.
You mean cosmetically, or you mean functionally, or both?
Cosmetically, functionally, just one does joints and the other one doesn't. Okay, which I'm so happy I was able to get exposed to that world, because it's a much broad spectrum world of us doing what we do nowadays in the cases that we showed. But I mean, you had in the background there, what you see right here, the way to look at the face.
Point the camera up at that, Doc, if you don't mind.
Sure.
Wow.
So the year that I spent with Dr. Wolford.
What year was that?
That was 2012. And the man works Sundays as well, by the way. But we sit down, and when he does it. He sits down and draws, does the tracings on the paper, and from a before and after objectives, treatment objectives and such. And still the paper that goes on top of another one, and drawing with pencil and such. So I would sit down next to him and I would do the same tracing, based on what the numbers were, the movements and such, had the same osteotomy design that you can see, the step osteotomy that's in the back for the sagittal split. But I kind of overlaid a few of these, and this is a painting that I made, which hangs in my consultation room, because it kind of reminds me of the origin of where I started my journey as a surgeon.
Mm-hmm. Yeah, and that's a painting that you made, Doc, right?
Yes. You
were telling me a little offline about how you have a side, I don't know if you want to call it a hobby, but it sounds almost like a co-profession as an artist.
I mean, I always talk about it, and this painting is in my lectures. I always mention right in that corner, this, to me, what I get to do is a marriage between art and science. And it's a perfect fit for me. It truly is. Because you have to, when you look at a face, a lot of artistry goes into that. It's not the same numbers matches everybody. There's a lot that you have to think about. That how, it's a privilege for a patient to trust you, to allow you to move these bones in their face and change how they look at their face after surgery. They have to be comfortable with that. The relationship between surgeon and patient is a holy one.
Yeah. So you never had trouble sitting down and doing a tracing like that, because have you always had a talent with art like that, being able to draw and paint and do visual art?
Yeah. I mean, I painted ever since I was a kid. My dad is architect, urban planner, and civil engineer. So he did his tracings, and I always loved that. He did his painting, and he did some painting as well. And he made furniture, so on and so forth. So I grew up in a family that loved art and music. Those were my two definitely outlets. That's the reason why I try to make some noise out of guitar and play with a band. Actually, it's called Pulmonauts right now. And that is a great outlet as well.
Can you show us some of your artwork as well, Doc? Can you show us what some of your visual art looks like?
Sure. Let me.
Yeah. So you do music too, huh? And when you say that's an outlet, you mean an outlet for balancing your life away from the OR, or do you mean just for artistic expression, or both? Or
let me see how I can set this up for us.
Yeah. And then I want to ask you about how I want to talk to you more about designing a surgery to make it beautiful, and what that looks like for you, and why some surgeons get that wrong and they do really ugly looking surgeries. And then maybe you can load up some cases that you're especially proud of, and you can tell us cosmetically how you thought about it as a surgeon and as an artist. Because obviously a lot of my audience wants a really beautiful cosmetic surgery. Of course they do. Who wouldn't? And there's just not a lot of trust that surgeons are delivering that these days. There's trust in some surgeons. There's skepticism toward others. People fear over advancement. People fear under advancement. It's like, what's the middle ground? And I would love your perspective on that.
No, I would love to talk about that because it is complicated, because now we have a world that's we're looking at airway as well, in addition to just aesthetics. So we have to be able to manage between the two of them. So this is one of my paintings, and we're going to get to that topic. Because it's an important topic.
Yeah.
So this is a Sassoon tracing of the face. You can see a patient with anterior open bite, obviously here, and class 3 relationship between the molars. But I love the tracing always, and I felt like it can be an art piece. And it is.
What's a Sassoon tracing? What's it used for medically?
So Sassoon tracing, for the most part, is kind of tells you the difference between the proportion between the top half of the face and lower half. And it's an obsolete one. It's not really used for surgery. I just thought it looks beautiful. That's the tracing that you saw behind me. That's more of a tracing that works for surgery. But also base of the skull surgery is somewhat outdated for me, because I work from the outside towards the inside. And that means I want to make sure to see where the soft tissue is going to be. And once I know where the soft tissue is going to be, then I move the bone in terms of the proportions that I think that makes sense. And also palpate the soft tissue, see how the soft tissue responds to the movement. And then the rest of it is matching the lower jaw to it, and the position of the chin to the true vertical line that goes from Frankfurt horizontal, which would be here, that goes from the porion, which would be ear, would be here, and the floor of the orbit. That line, I do my best to make sure that the buccal aspect of incisor is parallel to that. And for males, for the most part, I want to make sure that line, the pogonion, which is a bony aspect of the chin being forward, is somewhat close to that line. And for females, 4 millimeters or so behind. But it's different for everybody, because you also have to listen to your patient's desires as well. So
wow, this is really, absorbing for me to look at this. It's the red and the white and the lines, and the fact that I know it's kind of a patient that needs a surgery. It's just it's a powerful piece.
Well, hopefully, I'm going to be able to get back into the studio, which this is my studio. This is my dog who passed away, Zara. is one of those one of a kind dogs that, that you're going to have for life, have the privilege of having in your life. And she spent a lot of time with me in my studio, that is my studio, as you can see up top. And this is some of the paintings that you see, that I get to do. Yeah. This is great way to kind of dissociate from day-to-day work. One of my favorite artists is Redondo de Leon, and my color palette goes along with his what he does.
Yeah, it's an interesting color palette. It's kind of like an earth tony type color palette. Yeah, and it's very abstract. Yeah, abstract, exactly. And the dots, the way I work with the dots, and ultimately what works around it, and create a 3-dimensionality for the painting, that to me, and then rework it and make the depth. That's where it comes down to. To me, surgery is almost like a painting too. When you're planning a surgery, you're not going to get to the point of it's like, oh, this is just good enough. You know when it's finished. Or also surgery in the operating room. There are times that there are things that you might have to modify during the surgery, even though you planned everything, because not everyone's soft tissue responds the same. So you have to feel right about what you've done before getting out of the operating room. And belaboring the minute points of it, the amount of chin advancement, the amount of chin impaction, the amount of incisal show. So all of that, there's so many things that comes into play. And I just wanted to take the time to show you also this. This was, this is a music studio that I have in my house. And this was our band Pulmonauts that we played with. I'm not sure how much longer we're going to be playing, but, it's awesome to work with play with these awesome gentlemen and ladies to, make some noise as well. Are those just random people, or are these other doctors? That guy looks like someone I recognize in the red.
Yeah. So you have Dave McCarthy, Jerry Simmons, Samantha Weaver, and Tom Colquitt and Brian Huckle. But Tom.
Yeah, that is Brian Huckle. I thought so.
Yeah. And Tom Colquitt passed away. Unfortunately, he was definitely one of the most amazing people we had a chance to be around. Amazing gentleman. And Barry Raphael has his back to us here. He's an orthodontist, and so
in New York, yeah.
Yeah, in New York, he's a great guy, very airway aware orthodontist. So
you did Brian Huckle's surgery, right?
Yes,
yeah, he looks great.
I did his MMA, and it was
about a year ago, right?
2 years ago. Correct.
Yeah.
So awesome to play with these guys. He's an amazing bassist. So I make some noise out of guitar, but I'm probably the weak one out of the band.
Man,
but
you guys stay busy.
Hey, you only get one life, so
that's a matter of debate, actually, Doc. Some people would say otherwise, but that's a different topic for a different podcast.
As far as we know, we get just one life. Otherwise, I like to make sure that do as much as you can in this lifetime.
Yeah.
But what I mentioned to you, marriage between art and science, the perfect fit for me. That's why this kind of stands out for me. And
wow.
So a bit elaborating on that part.
Yeah. And I've seen a tracing from Dr. Wolford that he did about a year ago. I can't believe that he's still doing it on pen and paper, but man, it looked a lot like your painting. It was very visually striking. It was kind of so impressive to see an analog tracing like that. And I thought to myself, wow, this guy must be really an incredible person who has had such amazing experience from a different time. And yeah, it's cool that you've done a painting that kind of immortalizes Dr. Wolford's process.
Yeah. As I mentioned, I have prosthetic joints, obviously. So, and he's done mine, and I definitely owe a major debt of gratitude to him because he paved the way for us to be where we are.
What was so hard about counterclockwise rotation that made it such an innovation when Dr. Wolford introduced that into OMFS? What is it about that surgeons shied away from initially? What were they doing instead? They were just jutting straight forward? And why?
No. Actually, it's so amazing that you say that. So it is Dr. Prophet, who was he passed away as well. But Dr. Prophet, who was an orthodontist out of UNC Chapel Hill, I went to his course. I had the honor to go to his course, and Dr. Sarver now is basically worked with him quite a bit as well. And they were not big fans of counterclockwise rotation because keeping a counterclockwise rotation stable is very hard. Okay, and so you saw the kind of grafting that we do to make sure it's stable and the fixation and such. So I was very aware of that. That's the reason why I graft all the cases and make sure that the bone heals so that if the plates come out, we don't have to worry about lack of stability. So with that being said, that most folks, when they see an anterior open bite, they think they can posterior impact the upper jaw and clockwise rotate the mandible, and which makes things aesthetically look horrible. It's horrible for airway because if you really think about the nasal breathing that we have, okay? If you posterior impact the maxilla, you're going to have a very small space in the posterior portion of the airway that goes through the nose. That means you have to do a heavier turbinectomy in the back so the patient is not obstructed, okay? And also, in that case that we spoke about, you're bringing the chin back. Pagonion goes backwards. So you're already receding the jaw, so you have to come all the way forward. Then you have to do a bigger chin. I don't like genioglossalal advancements of more than 6 to 7 millimeters. Most of them don't look natural. Sometimes we have to do it for OSA reasons, and we can shave it down afterwards, or just to do a genioglossalal advancement by itself, which brings the muscle at the base of the tongue forward, opens the airway, hence opening the airway. So that is what oral surgeons always did, and shied away from doing a counterclockwise rotation.
So is the idea there that when you impact the posterior part of the maxilla, that there's no gap, and so you're just getting better healing, but when you rotate, you're creating the void? Is that the challenge?
Yes. That is for a posterior impaction. It's a matter of stability. There's bone-to-bone contact, number one. And also, if you have an open bite, if you do this and the upper jaw and lower jaw goes back, you close the anterior open bite, but you're still not taking care of the root cause of the problem, which is the joint. Because now the joint, you saw in that case, that patient still relapsed after 2 posterior impactions. Yeah. Okay. So if you don't get to the root cause of the problem, it's like a car that's as low, and it's, let's just say on the oil, but everything else, you're fortifying it so well, and the car looks awesome. But at one point, the oil is going to run out. Your engine's going to break. Yeah. Or like the car's out of alignment and you keep getting worn out tires, but you just keep replacing the tires instead of doing the alignment. So what did Dr. Wolford do to bring counterclockwise rotation and make it popular and stable? Did he just graft? I mean, is it that simple? Yeah,
did he use different plates or what? So
he did grafting, well adaptation of the plating, and elastics were 8 to 12 weeks. Posterior elastics were 8 to 12 weeks. You have to do it.
What's that mean? You lost me. What does that mean?
We're going to talk about that. So
this is the challenge of speaking to a layman about such complex surgery talk.
So you see that there's a counterclockwise rotation that's taking place here. Okay.
Yes.
And I get a
big void there.
Big void that you see there, right?
Yes.
But this is the custom plating that you can see here, the gap that you have here. So the bone that we take from the condyle, we graft to this space. First, we do the joint, because then the joint is the most stable for the lower jaw. And that's the reason why we do mandible first for double jaw surgery as well. Okay. Then we rotate the upper jaw down and forward. And posteriorly, you have that big gap. This is a big counterclockwise rotation. So to keep the posterior together, so you don't have a posterior open bite, running elastics off these teeth while the bone heals, which is at about 3 months. Once this bone heals with a block grafting that we do, then you have a stable upper jaw. You're not just counting on the plates.
And then you probably also have to avoid chewing tough foods on those molars, right?
So our way of going about it is the first 2 weeks is clear liquids to full liquids to PRA. And when we get to 2.5 to 3 months, we go a little bit more chewable stuff. Okay. And once you get to the 4 months, the upper jaw is healed. That's basic bone biology. Whenever we do a block graft to the alveolus, minimal is 5 to 6 months for the block graft to heal for us to put an implant in there. So us oral surgeons are amazing at understanding bone biology and reconstructing bone in the jaws. So
have you had patients sabotage their own surgery by just chewing too soon?
Oh, no, it's not. I'll tell you a few stories. So we had a patient that who fell post-surgery, broke her jaw in 3 places. Actually saw her 2 weeks ago. Then I had to put a reconstruction plate to put it together. The second time reconstruction is never as good as the first. Patients that went ahead and played basketball and wound up getting hit in the face.
Like within 4 months, you mean?
Within 2 months.
Oh.
Yeah. And I mean, like, I'm very protective of our patients and their outcomes. So that patient also did that. I had a patient that fell in the kitchen, came by herself, fell the first week and a half, fell in the kitchen and broke the upper jaw and caused infection, so on and so forth.
Oh.
It is, yes, patients, but, I mean, I'm not the first one to have had this. I had a patient who was a violin player. So she couldn't get away from an instrument. Okay. So played the violin and the upper jaw migrated.
Come on.
Yeah. I mean, like, you do this long enough, you're going to see a lot of things happen.
How about sleeping on your side? Sleeping on your side? Is sleeping on your side a no-no?
It's for me, to a month and a half, I tell the patients to sleep on your back, elevated, 2 pillows on each side. I mean, I know that I've given them a stable outcome, but I don't want it to move an inch. 0.5 millimeters, excuse me.
Wow. Yeah. These are the things that people don't think about. But yeah, there's that critical 4-month period post-surgery where you have to really support the surgical site to make sure things don't shift.
Absolutely. Absolutely. It's not, and orthodontically, you cannot take your eyes off the posterior of the counterclockwise rotation. The elastics have to be in place for 8 to 12 weeks minimum. Minimum. There are orthodontists that say, oh, take out the elastics. No. Absolutely not.
And the elastic is essentially just creating a tensive force, keeping that segment, keeping the posterior part of the maxilla coming downward so that it doesn't impact back up. It's essentially
actually elastics does 2 things. Okay. So if that posterior part, because you're fighting against a lot of muscles, the elastics will keep that together. So if we have a millimeter open bite, 6-ounce elastics, we're going to go a little heavier. And to keep that together. But also, what the elastics are going to do, are going to train the muscles and fascia. This is where you want to open and close to. So proprioceptively, we reset everything. And then what this does will adapt you to the new reality. Your body is confused proprioceptively post-surgery. It's like, where's the tongue? Where am I? What's going on? And you look at and also as far as the biting, where am I biting into in this 3-dimensional space that is foreign to me? Okay. The other part that is important to know. I mean, we ask the patients to do my functional therapy and physical therapy before surgery, to strengthen the tongue is important, ahead of surgery, because surgery is like a full-on reset with the tongue. The tongue goes down and back when you do surgery because it's confused. Everything is in spasm. Muscles of the face are in spasm. So, what happens is that then if you have a stronger muscle, you're not going to lose as much. Okay. You can pick it up at a certain place and move forward. But if you have a tongue that is just flaccid as can be before surgery and hasn't been exercised, okay, and that tongue is going to be way down and back. So you have to do a lot more hard work to get it up there.
That's probably something you pick up on in the DISE, right? And that's something we should maybe touch upon.
Yeah, we should talk about, so in the DISE, not so much about the tongue. Actually, I would say sagittal's view which is a side view of, the scan is what tells us a lot about that. But in the DISE, we're just going to see the because in all reality, and Dr. Kazarian says that, hey, listen, you give anybody enough, propofol, during a sleep study, their tongue they're going to collapse.
Is he an anti-DISE guy, Dr. Kazarian?
He's not so much anti-DISE, as a matter of fact. It's a comment that he makes about the DISE. That you're going to see a lot of collapse with DISE. And I really like Dr. Kazarian. I think he's a great surgeon,
It's a big criticism of the DISE is that when you give anyone enough drugs and they'll go flaccid.
That is not true. Not true.
Dr. Casey Lee feels very strongly against the DISE.
No comments. But moving on from there, the way I would put it is that what we're doing with DISE now is awesome because it has given us somewhat of a grid work and knowing how much to move the patient forward. And besides, when you do the DISE, you can't just say initially give the patient a certain amount of medication and say, okay, you know what? That is the best image that we can get. You got to let the patient's fight and flight calm down. Okay. And with the first 10 minutes, you're just getting to that awesome zone. And they ultimately, initially, they're going to be collapsing no matter what. Okay. And when 5 to 10 minutes has passed, their system is off the fight and flight and so on and so forth. And or response to the medication, then you get to the zone that, okay, now the tongue is going back up a little bit. You feel that there's sleep. You're going to look at the stomach and see, if you're using accessory muscles for breathing and such. And then you're going to do the DISE. In those images, the image of DISE from the first 5 to 10 minutes to the 20 to 30 minutes into it, so different. Same position. So different.
Wow. There's really a lot to it, isn't there?
Oh, so much to it. So much. But you know what? It's the best thing that we have to assess if a patient has concentric collapse of the soft palate. It's the best thing to have for us to understand at what movement, for example, the patient is going to have a good opening of the airway, at least close to it. Okay. It's a good way to tell the patient, you know what? You might need some soft palate surgery ahead of time. I think your situation is a lot worse than we thought.
Would that be like a Ehlers-Danlos patient that has a really long soft palate?
Oh, long soft palate. You want to see what the nature of that is. You know what? We have to trim that soft palate a little bit. Maybe we need to do a very modified expansion pharyngoplasty after the double jaw, because a lot of concentric collapse cases could actually, basically, you can actually treat concentric collapse with MMA. We can see that.
What is concentric collapse of the soft palate?
So when the soft palate closes like a sphincter in this fashion, and it's not just AP in this fashion, that's concentric collapse. And that's the hardest one to treat.
So it collapses in from the sides, it three-dimensionally collapses?
Front to back, yeah. Front to back, we do front to back versus a round closure. That's the hardest. And that's the one that Inspire doesn't does anything for. If you have the concentric collapse, Inspire can't do much for it. Then you have to have a soft palate surgery.
Wow. I'm not sure I've ever heard anyone distinguish between different types of soft palatal collapse. Is concentric soft palatal collapse, is that related to hypoplasia, or is that almost like a congenital thing? Like does that if your jaws are too small, does that lead to, like, if your maxilla is set back, does that lead to concentric collapse?
I think it's just the way the soft tissue collapses. I don't have a good answer for that, so I would say I don't know.
Okay.
I just basically witness what I feel is the problem and ultimately what the treatment would be, but I can't really make a comment on that part, unfortunately.
Well, how do you treat that?
Concentric collapse?
Yeah. You just slam the maxilla forward?
Yeah. Bring a maxilla forward, MMA. And ultimately, I'm actually looking for the slides for us, but MMA would be what would take care of that for us, for a lot of cases. And if it doesn't, then we go to the soft palate surgery. That's why do you refer out
for that to like Dr. Kazarian?
Yes, you know what? I reduce what I do to the already extensive number of procedures that we do. And I don't have to do everything in my practice. I want to be the best at the small area of what I do. And that to me is what matters, really.
Yeah. Specialization is everything these days.
Yeah. There's basically, I would say to most folks that I'm the best at these three procedures. Sagittal split osteotomy, Wolford, and total joint replacement. And there's so many modifications of that. That's enough for a lifetime.
Oh, gosh.
To be frank with you.
Yeah.
There we go. I found that for us.
Yeah. Fire that up on the screen share.
Sure.
Do you see a lot of patients that have primarily soft palatal collapse more so than tongue-based collapse?
So actually, I see tongue-based collapse more than anything.
Right. But have you ever seen only soft palatal collapse?
Yeah. Oh, yeah. Absolutely. Actually, some class 3 cases have sleep apnea. Those are the cases that have that.
Yeah. I didn't even think of that.
Oh, totally. And that's a big concept of itself.
I think that's my problem is soft palatal collapse, because when I'm laying down, I can actually feel my soft palate collapsing as I'm like between awake and asleep.
Yeah. So
and my DISE showed that. My DISE showed that.
Your DISE showed that, but Mike, then you know. So the Nyxoah system, which is bilateral hypoglossal nerve stimulator, which I think about a month or 2 months ago got FDA approval. Everyone's excited about this, by the way, because it's a bilateral hypoglossal nerve stimulator. They say it has the ability, potentially, to take care of the concentric collapse.
Is that made by Inspire?
No, it's this Inspire's competitor, as a matter of fact.
Oh.
So it is. I really hope for some of those folks we're going to be able to have this. It would be amazing to have that. But yeah, we're going to have to wait for the data.
Okay.
So it's a very simple thing to do. Drug-induced sleep endoscopy, as you can see here, right now we're looking from the top. That is the lateral wall on the right and left side, and that's the soft palate. You have more of an AP collapse here. Okay. And
can you help orient us inside of this patient's head, Doc? I'm sorry.
Sure, let's do it. Oh, no worries.
DISEs are so hard for me to follow.
Yeah, it's so this is where the adenoids would be. So this is the pharyngeal wall. That's the soft palate right there.
So the patient's maxilla is where? It's at the bottom of the screen.
Yeah, this is forward. That's backwards.
Got it.
Okay.
Got it. Yeah, please walk us through it.
Yeah. So at a certain point, here, we're doing it the classic way we used to do it. We just push the lower jaw forward. We don't know how much. You saw that? Mm-hmm. You know, at the end now, it opened up. We don't know how much we pushed the mandible forward. So that's what I wanted to fix. And let's take a look at another DISE here.
Mm-hmm.
Okay, so this has a bit more of a concentric collapse component. You see that circular collapse that you have here? Like, you see that? Mm-hmm. Now, the other one was AP front to back. It was almost like a collapsed tube. This is like a collapsed straw.
Mm-hmm.
That's the difference between the two of them. But
wow, that's nasty.
That is nasty, and then now we advanced the patient. It got better, but it's not the best. So that gives us the ability to tell the patient, hey, you might need soft palate surgery, and knowledge is power when it comes to this. Mm-hmm. But the way we went about this, as you know, when we bring the upper jaw and lower jaw forward during MMA, that's how the airway opens up. But for the DISE VSP protocol that we have, which Dr. McBride, myself, basically came up with this plan of doing this, and we virtually planned for different advancements. And here's a patient who allowed me to use her before and after, basically, for our publication. So this ultimately is going to be in the publication. So it also tells us how far the patient can come forward. So there's no advancement on the left side. Soft palate is completely collapsed. At 4 millimeters, the soft palate opens up. Okay. So at 6 millimeter, you can see the top is a 0, bottom is a 6 on the left. Mm-hmm. And also with the splint in, you can see how the soft tissue changes. Mm-hmm. And on the right side, that's 8 millimeter advancement of the lower jaw. So we put the lower jaw at 8 millimeter forward. And now you can see all the way down to the epiglottis. You see that? Mm-hmm. So now we have the information that, you know what, at 6 things are going to work out. 8 looks awesome. And the epiglottis opens up for us nicely. And you can see all the way down from the soft palate to the base of the tongue, and there's no obstruction. So we ultimately planned her, and this is what we were able to get. So we went from minimal cross-sectional area of 53 to 164. And you see, this is right after surgery, as a matter of fact. The tongue is down and back. Ron, that's exactly what I was telling you about, that it kind of resets the tongue in terms of its tone is concerned. But that's why we have to do myofunctional therapy after surgery, to bring that back up to the roof of the palate. And also what you see hanging out behind the incisors, that is the palatal splint that maintains the width of the upper jaw.
Right.
No segmental procedure should ever be without a palatal splint.
Mm-hmm.
Okay.
Mm-hmm.
If you can on your custom plating to keep that together, you're mistaken. You will have collapse.
Wow.
So
do people
100%.
do that? They'll do segmental with custom plates only?
Only without a palatal splint. It's an absolute mistake. A palatal splint, and this is, what I learned early on. Without that, you're not going to have a good outcome, a stable outcome. So, and this is a patient before and after. She wanted a very subtle change. You can see that from the front, from the quarter shot view. She didn't want to be too prog. Aesthetics was important to her. It's a maximum, and we moved the maxilla 8 millimeters forward. So the maximum we were able to take care of for her. Okay. And that's how the airway changed for us.
Wow. Remarkable.
So that's the benefit of it, to have a point of reference. Okay. Having that point of reference is what was also, to me, is what's important. So the more data that we have, the better. The easier it is that we can make a decision. Yeah.
Doc, can I show you my DISE and you tell me your thoughts on it?
Let's take a look. By all means.
Can you see this?
Yes.
Is it clear?
There we go. You got to see just a little bit lower of it. But yeah, it is clear. Yes.
What are we, is that my soft palate?
So yeah, that is your soft palate where you're seeing on the bottom, the genu. And what you see on the right side, those are the lateral walls. So you're a little more wet here so if you notice, our DISEs are very dry, right?
Yes.
So because we use anticholinergic medication and we wait for 20 minutes before we even start the procedure.
Right.
So that dries you up. It makes for a much better DISE.
Right. So this is amateur, huh?
I'm not going to say that.
Well, it's okay. Yeah, that's okay. I'll say it.
Yeah. Yeah, it is. It is not the way I would do things. Yeah,
you can't see anything.
Yeah.
Yeah.
So
Okay. So
you do have collapse, but I would put that probably as a partial collapse at a soft palate, and this is without advancing you, right?
Correct.
Oh, your epiglottis is staying nicely, but also you have to look at the tongue. See, right now there is no space between the epiglottis, and one of the things that we do with a scope, we go and look underneath the epiglottis. To see if the tongue base is pushing on the epiglottis, pushing it back, but your epiglottis is standing very erect and nice. That's good.
Well, that's what I'm saying. I feel like my tongue base is okay. It's my soft palate that's collapsing.
It is. You're right. Yeah, what you feel is right. That is a really good tongue base.
I think it's because I've been like mewing, so to speak, and myofunctional therapy for like 10 years. And, I think it is my soft palate.
Yeah, I would agree that that's the case.
So,
I mean, there are some, I know that soft palate surgery has been very much looked down upon, but in the right hands that treat the soft tissue nice and no Bovie is used, you can have an outcome that is not too invasive if it's just a soft palate to take care of it. Or you can also think about stiffening some radiofrequency that could help out with the soft palate to prevent that collapse potentially, and then do a DISE and then discuss, hey, maybe just MMA to see how that's going to work.
Do you think that, based on what you've seen here though, that advancing the maxilla, even if it was a 0.5 centimeter, which is what has been proposed to me, between 5 and 7?
I think 7, if you're doing it, I would go for 7. You don't want to do that big of a surgery and just go for 5. Average 7 to 8 millimeters. Yeah.
Do you think, and I know this is just informational, you're not treating me, you're not even giving me real medical, but do you think I could really tolerate that much?
Let me see. If you don't mind, make your view a larger view. So one of the things that I do, I manipulate the soft tissue, okay, to see how much the lip comes forward and how the nose responds, okay? because when you do this, sometimes the nose rotates up. So if the nose doesn't rotate up for you, and if you don't mind, just like sit like this and have your neck straight also. You have a longer upper lip length. So for me, I think just by looking at you, the tip of the nose is rotate down a little bit. So I think you can have a advancement and potentially some counterclockwise rotation for the chin to come forward a bit more. So I would say that is possible, but I have to, for me, is to see you in person to know how that soft tissue responds.
And even if it was, so let's say my soft palatal collapse is kind of minor, right? And I could do a smaller surgery, but still get the fix. It's like a lot of people say surgery is only worth doing for a centimeter or more. I think that's such an arbitrary statement to make.
No, and that's the part about it, is that is not a correct way to go about it. That's the reason why doing a DISE and knowing what your problem area is makes all the difference. For example, if you just had base of a tongue issue and you had a high occlusal plane, I would say come forward a bit here, then counterclockwise rotate it so the base of the tongue opens up. But if you don't have that part of information, you're flying blind.
Yeah.
So no, I don't agree with some of the folks that you mentioned that don't think highly of DISE because they're not using it appropriately. Because also, if the patient has the DISE information, let's just say the MMA has 86% success rate. Okay. No one has 100% success rate.
Yeah.
I had a patient that did 4 years ago, moving forward, high numbers in upper jaw. Okay. He still has about 20 apnea indices. It's going to be, it's going to be a Inspire case. Because I just did his DISE, sent it to the ENT I work with. He said that pattern of collapse is perfect for Inspire. Combination of Inspire and MMA is potent. Stanley talks about that often, and he has it. Stanley Liu talks about that often, and he wrote a paper about it. I mean, like, it is not. Like, we can all just sit down. It's so complex. It's A, B, C, but you have to have multiple lines of therapy for the problems that are presented.
Yeah.
But the more data you get ahead of time, the better. So if the DISE shows you that you have concentric collapse, you've already prepped the patient so they don't have surprises. It means, like, you know what? You're potentially going to be in that 14%, 6 to 8 months after surgery. We'll do another DISE, see where it is, and a sleep study. And then let's go on from there. Then we're going to go very targeted. Like, you've done the heavier lifting. This is going to be a smaller procedure for you.
Yeah.
It's so important not to overpromise of what this procedure can do. Because not everyone's soft palate is the same. Not everyone's base of a tongue is the same. Not everyone's soft tissue is the same. Yeah, no doubt. Yeah, what an awesome analysis of DISE that was. And thank you for looking at mine. No problem.
It's an interesting insight. Yeah, you kind of reflect what other surgeons have said, which is, some modest movement is probably possible, and it would probably be, 5 to 7 at the maxilla, and it would probably solve that soft palatal collapse issue that we're seeing on the DISE. And mind you, my issue is not severe. It's like a RDI 15, right? So, which is an AHI like between 5 and 7. So it's pretty mild, but it's in probably maybe even not worth treating. And I haven't treated it yet. Like, here I am. I'm not scheduled for surgery or anything. It's just, I'm trying to just understand what I'm dealing with anatomically and why it is that my sleep is not great.
The question is this: are you desatting at night? Below 90?
No.
That's a big part of it. But, fragmented sleep, as we all know, could result in, early Alzheimer's and such. That's what they're talking about. Dr. Ployo out of Stanford mentioned that. Actually, we've known that from other sleep physicians as well. But in modern day world that we live in, I don't know how many people can get a full straight night of sleep. At least in my life, I can't.
I don't. Yeah.
I don't. Yeah. I know we have these expectations that, that, hey, your longevity has to do with A, B, and C. But I mean, look at the greatest generation that to talk about, the folks that, went through World War I. Those guys barely had normal sleep between PTSD and everything. And they have veterans that live to 90s and such.
Yeah.
So making these blanket statements and thinking that life is a perfect, stream of, happiness, and every night, everything being exactly the same, and everyone's going to have this perfect sleep hygiene. I don't know. That would not work for me.
No.
I get a call from hospital here or there. I have to respond to things, have things on my mind, wakes me up. So, yeah.
You know what a good night's sleep is for me these days? It's like 6 hours from 9 to 3.
Yeah.
And I wake up, and if I wake up, no headache, I feel amazing. And it's like to be honest with you, when I sleep more than 6 hours, like let's say I go back to bed after 3 and I sleep from like 4 to 7 and I get 8 or 9 hours, I feel awful. So
Ron, I got news for you. The older you're going to get, less that sleep is going to be. And I don't know exactly how to, I'm not a sleep physician, and I'm not going to sit here and pretend to be the know-it-all person. I can just tell you what my experience has been. Yeah, I'm waking up earlier. Okay. I can't help it. And I'm going to sleep earlier. So that's changing. That's absolutely changing. So you got to go with what your body also, expects of you.
Yeah. Yeah. I used to live at this Buddhist monastery for a couple years from 2013 to 2016. And the monks would have a rule where you were supposed to sleep no more than 6 hours a night. Any more than 6 hours a night was considered sloth and torpor. And ideally, you sleep no more than 4 hours. And so that gave me it set this precedent that like it is possible to function on less sleep. And it is to some degree, and I know there's probably going to be a lot of hate in the comments about this is cope or whatever, but yeah, it is kind of mental. Like I used to, when I woke up at 3, I used to force myself back to sleep and toss and turn. Yeah. Now I just roll with it, and I can go the whole day and I feel amazing.
Wake up and get going. It is. You're right. That 6 to 7 hours is just right. But that means also that night you got to go to sleep earlier.
Yes. Yes. Yes.
Yeah. My days of going to sleep at 10 or 11 o'clock is very much over.
Me too.
I have way too much to do during the day and patients to take care of and things to worry about, and it's overwhelmingly exciting world we're living. Comments right and left, reminders right and left that at a certain point, you just say, okay, that's it. This is the end of my day.
Yeah. Doc, do you have time for 2 more topics that I want to discuss with you? Or do you want to? Yeah,
absolutely.
The two more things I want to discuss with you are surgical planning and what that's like in terms of timing for the patient and collaboration with the patient and determining the final sort of aesthetic target. And then the last thing I want to talk to you about is MMA, MME. Yeah.
MMA.
Yeah,
and
MMA.
The one other topic that one topic that's really, really important, Ron, talk about is the longevity of the joint. That people, we got to talk about that and how we already spoke about how we do the procedure. But if you talk about that for like a 5-minute thing, I'm going to just grab some water and I'll be back.
Yeah. Okay? Let's take 5. Okay.
5. Sounds good.
Okay. Perfect.
See you in a bit.
So, coming back from our short break, we're going to talk about where did you want to start, Doc? Did you want to look at the longevity of the joints?
Yeah, the longevity of a joint is very important, Ron, because a lot of what I hear out there, and we're going to talk about it, is the misconceptions that people have about the joint. So let's dig in a bit about that, and because everyone thinks this joint will break in 10 years. Okay. And it couldn't be farthest from the truth. And I'm happy to have the ability to, get to the masses and everyone out there that they should not be afraid of the longevity of this joint. It's a lasting joint that we have, but I'll tell you what would be anecdotal, what would be basically, what we have scientific already in our hands. So, I can think of that. There was a day in, 1891 that a piece of ivory was made for total hip by Dr. Clock, and it wasn't really till Dr. Sir Sharnley, who came along and made the ball socket joint for the hips. First 3 years, he had nothing but failures because what he's holding in his left hand is basically the socket of it, which was made out of EPTFE, and that failed miserably. And if anyone gets a chance to read this book, because it's it's an amazing book regarding his life and, who he was as a person, which is an interesting individual. When he came up with the idea of, total hips, the first year was about 50 somewhat cases, about 180 revisions the year after. So they went through their hardship, but they then figured out that guess what? The housing of the joint is supposed to be high molecular weight polyethylene for it to work. 80s was a bad era for us. We had all these joints that failed right and left. You can see the lower left one, that's a Christensen one, in pieces. And then the one that you have on the lower right side, that's Proplast Teflon.
Can you exit out of the screen and use your scroller to point out what you're talking about?
So you can see this is metal on metal here.
Yes.
Okay.
That's not the way.
Down. That's not the way to do it. Then they had the Proplast Teflon. That one failed. Wound up a foreign body giant cell reaction. And these poor patients, they really suffer through it. Okay. And it wasn't really till we got to this era. And if you look at here, that we have, was the metal on metal. And then we realized that we have to have it as high molecular weight polyethylene against basically the titanium, which has a bit of cobalt, chromium, and nickel in it. We can make it out of full titanium also, which doesn't make any difference in the stability. And we owe that to Sonneberg and Sonneberg. They were the ones that basically in 1995 figured out that this is what's going to work for us.
What is it about that plastic material that works better than metal on metal? Because I assume that thing feels rock hard, right? Or is it a little softer?
It's a bit softer when you kind of make a bit of instrument. If you go over it, you can make a line on it. But how it compresses against the metal, it is very stable. It doesn't fall into pieces. It doesn't break apart. And we have, as a matter of fact, and I will show you in a bit, because we're going to talk about the longevity of it. And this is one of the things that really made me believe in this joint above and beyond of what I already believed in it. So I'll show you actually one that is 21 years old. But so the joints that we have now available to us, from the Sonneberg, we got to Biomet and then TMJ Concepts. And it wasn't until 2005 that we had full-on FDA approval for this, of the system. Okay. We always talk about the fact that form follows function. And the primary goal of the joint is to really safely and effectively manage anatomical, functional, and aesthetic discrepancies, just like you saw in that Goldenhar case. Okay,
yeah, Doc, have we seen what the modern joint that you're currently using looks like? Is that what it was from that previous slide, or are you sort of saving that for later?
So I can show you the modern joint that we have right now. In the slide that's going to come up, I'm going to show that how it looks like.
Okay.
But if you look in the camera, this is what the joint looks like.
Oh, okay. So it's a metal anchor into the cranium, and then there's a plasticky fossa.
So let's put it this way. What you have here is the metal mesh that, with the process of cold flow, the high molecular weight polyethylene is attached to it, which they don't come off. And if housing is stabilized with the screws, and then the mandibular component is here, which attaches to the lower jaw. Basically the ball and the socket. Okay. So this functions right in there for us. And
wow.
And not a single one of these, Ron, not a single one of these have worn out after 38 years of the company being around.
So this design has been pretty static for decades now.
Oh, for decades. And, the indications were initially only for when the joints fuse, end stage joint disease. Now, as you saw, for example, this paper on the right side that we wrote, it was indications for allopathic total joint replacement for OSA patients. I'm actually writing another chapter on this for Dr. Liu's book, but we're using it for all sorts of craniofacial defect and deformities, and also advancements and ICR, as we mentioned. We saw this is what the joint looks like by itself, as you can see. The housing. And the white portion would be the part attached to the housing, and the mandibular component has the screws that stabilize it to the ramus.
So why is that top component that attaches the housing? Why is that a mesh? Do you actually graft inside of that?
So no. What's great about that is that you see the grid pattern that it has.
Mm-hmm.
It actually osseointegrates to the fossa, so it becomes stable.
So the bone kind of integrates into the mesh?
Yes.
Without you grafting into it?
Without us grafting into it, because this is custom made to the patient anatomy.
So that sits tight to the patient's bone?
Oh yeah, absolutely. It fits.
So the bone goes above it. The bone buries the screws in the mesh eventually.
Yeah, exactly. It's,
okay.
It gets screwed to the bone above it, which is basically the eminence, which would be right here. Okay.
Yeah.
That's where it gets screwed to. And we only need 3 to 4 screws up top. But it's not a load-bearing joint, so you're not functioning on it all the time. In a lecture recently, someone said, oh, it is a load-bearing joint. Because how about when you're swallowing? I was like, as far as the PSI pressure on it, it's only when you're eating that the PSI pressure goes about 200 maximum. Okay. So you're not constantly on it, because total hips and knees, 3 to 6 times your body weight, you're on your hips and knees all the time.
Right.
And
is that why you needed to find that perfect socket material, which is kind of a hard plastic, to handle some of that absorption of the force?
Yes, some of the absorption, and also you're not wearing it, you're compressing it. Okay.
Yeah.
And there's even better news about that and this is from Dr. Moshiri. And so the high molecular weight polyethylene, even if there are particles, they won't go into the myocyte of the heart, or it won't go past blood-brain barrier. Okay?
Because they're too big?
Exactly. It wouldn't even pass and go there. And cadavers that they dissected and looked at histology of it, none of it was present there. So, and that's from the orthopedic literature. So that's fantastic to know.
But I mean, do people really worry about microplastic absorption from this little joint when people are like eating and drinking that shit all the time?
Exactly. Yeah. But listen, we have to answer these questions scientifically, right? So we have an answer for it. So, and you know what? After 21 years, I have this, one of them in front of me. So after 21 years, if you look at the fossa, that's all the compression that took place.
Show us on the screen with your scroller, Doc.
Yeah, let's do that.
If you don't mind.
Yeah, absolutely. So what you see here, that's all the compression.
So this is the joint flipped upside down.
Yes, flipped upside down, and I have one of them right here. Okay.
And what did that look like before? I mean, wasn't it already concave before? So what?
It was already concave. That's normal concave. But if you look really deep inside of it, then you see that little dimple. That's all the wear it had after 21 years.
It's just a little pitting.
Little pitting. Small, shiny pitting.
Not enough to affect function?
No. Not at all. I mean, the only reason why we had to take this out was that the reduction of the bone underneath wasn't adequate. The surgeon who placed it didn't reduce enough bone here. So the bone grew upwards and grew from the middle. So there was a lot of heterotopic bone around it. So we were like, okay, we're going to take this out. We're going to just put a new one in for you. You know, this is the only case that we had to do like this 21 years later. And we got a chance to get an insight to what it looks like and how the wear is. And the wear is minimal.
Wow.
Minimal. I mean, the image speaks 1,000 words by itself.
So what's the motivation to design new joints? You said there's some new ones coming to market. What's the point?
I mean, I got to tell you, in a lot of ways, there are a couple of things, actually. Let's talk about that. One of is that one of the things I always wanted to see change about this joint is being able to make these screws that you see here. I wanted these screws to be I wanted these screws to be locking. So the new ones have the locking mechanism, which is awesome. And you can digitally design them. But I mean, like, this joint is tested, you know, and been around for 38 years. So the other companies between KLS Martin and also Synthes, Johnson Johnson through Materialize, ultimately going to be working on their joint. And KLS Martin has also their own joint that's coming out in Rome last year. They had a meeting that they kind of unveiled their joint. So it would be awesome to see when that's going to be available in the United States, if they're going to do it. But there are 2 other joints coming to the market this past month and a half. As I mentioned, we spoke yesterday, monthly between 120, average of 120 cases are fabricated. But last month, globally through TMJ Concepts. There are other companies outside of the United States. South Americans have their own joint. Basically Germans, and in Europe, they had their other joints. This is the American joint with the highest amount of retrospective that we have, and study. So it's a great material, great, device. But they wound up having an order of 300 for the month. More than twice what they usually get.
What accounts for that?
Because I think patients with ICR, patients with joint issues know that there is an option, and they're not afraid of it anymore because patients were made afraid of it by others, and that's, as I said, this is what common misconceptions that sometimes surgeons that do only double jaw tell the patients the TMJR needs to be replaced every 10 years. It won't last. You'll have a poor outcome. I wouldn't do that to my child. You keep this procedure for the old age. The longer you wait, the success rate is going to go further and further down because you're going to have a lot more scar tissue built up, and the results are not going to be as good. Same happens with total hips and knees. Okay. And, the part of it is that how do we go about that, planning and utilization of this joint? And that's the paper that we published. This is when I was in my fellowship, and I wrote this paper literally in 45 minutes, with Dr. Wolford and Marcus Steshka. So a protocol for concomitant temporomandibular joint custom fitted joint reconstruction and orthognathic surgery, CAS, computer assisted surgical simulation. So, we've also published it in clinics of North America. And we are coming up we also in a chapter that I had in our book, which is a textbook for sleep apnea. We also updated that with the STL files, and I'm working on the custom plating along with it now to show that protocol because we've done a lot of that. So first we take a scan of the patient, put it in the basically virtual planning setting, and then first move the lower jaw down and forward, which is the part in the middle. Okay. And then
scroller, doc.
Sure. No problem. So this is a right side is when we first start. Okay. And what we do with that is this is just putting the CT scan in the 3D simulation world. And then we move the mandible down and forward, at least in this case. That red part of what you see, that is basically the intermediate splint. You see the mandible is a much lower and forward position. And then we do the segmentation of the maxilla to match it to the lower jaw. And you can see there was a counterclockwise rotation here. Okay. And then what we're going to get is, let me put this on play. On the left side, we used to have to shave down the red areas of the ramus. We don't even have to do that because this custom joint is so accurate. It fits like a glove. It just literally clicks into position because of an anatomy. So then the joint is fabricated. The joint is fabricated and also verified by fitting it on the model that you can see. And that's one of the models that I have here. It's fit on these models to make sure that it fits both in the CAD/CAM, the virtual world, as well as the physical model, serolithic model. You
verify that prior to every surgery?
Yes, the company does.
Okay.
And they have wonderful engineers. Eric Wren is one of the best engineers that the company has that I have an opportunity of working with. He's phenomenal. He makes sure everything is in tip-top shape for us prior to getting to the patient.
Do surgical engineers need to get any kind of certification, or is that just a job that people learn on the job?
Well, first they have to be engineers, yes, and then a lot of this is very unique to them. So now you have the planning people. That's why combining the orthodontic and TMJ world, that paper was so important, and it was kind of a very much a landmark paper, because now we're combining all of that in the virtual world. We're working off of the same template. Previously, we had to do the model surgery on for teeth on a articulator in the old world, which I did in my fellowship, and then in the upper jaw, and then the total joint would be made by us manually positioning that skull component. Now the skull component is printed in one piece, and everything is all done under the same roof. The movement of the jaws and the joint and the segmentation, all of that. So we've gotten so much more accurate with what we do. But the typical way that we go about doing this, you can see the difference between an arthritic joint on the right side, normal joint on the left. Orthodontics, pre-surgical orthodontics, just like any other surgery. Okay. Here, the sequence is out because we do the lower jaw first, but they're showing the upper jaw first. But this is the best video that we have. I use custom plates for that, obviously. And then the lower jaw comes down and forward. And look at how the lips come together with the counterclockwise rotation. Okay. And now it's showing that the fossa goes in and it's stabilized by 3 to 4 screws. And the bone that gets taken out, that's the bone that I reuse. Okay. And the mandibular component goes in. 6 to 7 screws is all that we need. And now bite this together. You have the most stable outcome with this.
Wow.
And then finishing orthodontics, 4 months, the upper jaw will heal. And that puts us in a really beautiful place. So this is, and when we do this, Ron, one of the things to talk about here is the fact that you have the masseter muscle that would be attached here. You have the medial pterygoid that was attached toward the inside, and the lateral pterygoid that would be here. Okay. Lateral pterygoid is attached to the head of a condyle. When that bone comes out, one of the things that happens, our side to side movement goes away. And, I eat everything, so it doesn't really affect me. But in order to mobilize the jaw down and forward, we detach the pterygomasseteric sling from that small incision that you saw there. So now the mandible is mobile to go in that forward position. You notice no cuts are done here. All the movement happens from here.
Yeah, there's no BSSO.
No, absolutely not.
Yeah.
Because, and was hoping I'm going to have a cursor to show that. But that once we detach the condyle, there's no attachment at the hinge. The muscle here and here are detached as well, but reattached when we close. And the jaw comes down and forward, or whatever position it's got to go in.
How do you reattach a muscle to bone?
So we make a couple of holes here and suspend it off of the inferior border.
With what?
With sutures, with thick sutures. And also, don't forget it, there are receptors that will guide the attachment of the muscle to go to the bone.
So it integrates after some time?
Oh, yes, it integrates after some time. And with that being said, it's like there's not a single one of our patients who had issues basically with mastication afterwards.
Is that similar to what happens with this muscle when a genioplasty is done? It has to be released and then reattached, or am I getting that wrong?
Genioplasty, you want to have the muscle attached to the bone, or genoglossal advancement. You want to have that muscle attached to the bone that you're going to move. And let me find a good model to show you that.
But I'm referring as well to the muscle that keeps the bottom lip moving. This one that when you do this cut, you can see it attached on the outside of the mandible. You know what I'm talking about?
Let me actually hold on a second. Let me stop this here and share. Go ahead. Tell me.
Yeah. Well, when I was watching Dr. Alfie do surgeries, I shadowed him for a day, and he would open up the gums on the bottom, and there was this big muscle.
Oh, you're talking about the mentalis muscle.
The mentalis muscle, yeah.
So that's a different muscle. Yes. So we reattach, because if you don't reattach that muscle, what happens is that you can wind up with what's called the witch's chin. So the muscle falls down, because if you do a one layer closure, the lip and that musculature will come down. So those are the mentalis muscles that we have here. I reattach the fascia in the middle and the muscles on two sides with sutures that are going to last longer. I usually use PDS sutures. And then above it, an incision that we make, I close that with chromic gut suture, which goes away faster.
But it's a stupid question, but how do you suture muscle to bone? How do you
It's not muscle to bone, because when you do that detachment of, or we cut through the muscle, you can see the muscle. So you go to the very insertion of the muscle, put a suture in, and put a suture into the muscle and suspend them together. Sometimes, actually, that's a very good question, that you can talk about. If someone has, basically lips that are not competent and the closure of the incision wasn't done right, we could put mytech anchors with heavier sutures to resuspend that soft tissue up. Okay. Mm-hmm. That's something else that can be done.
Wow. Fascinating. Yeah. Thank you. So really you're actually suturing muscle to muscle, because there's still the attachment point of the muscle that's integrated into the bone. And then it's like you're cutting the muscle, you're separating muscle, and then you're reattaching muscle to muscle.
Yes, absolutely. And it's so easy to see, and I don't do my incisions with any bovie There's folks out there that do it. All my incisions are with a cold steel blade, and it gives you the cleanest, less amount of swelling post surgery and such. So I do the least amount of bovie which kind of burns the tissue and stops the bleeding and such. I do the least amount of that. To me, if you do that, then you're going to wind up with more swelling, especially the nerves in this area. Personal experience, nerves in this area are very sensitive. So if you use a bovie in that area, the nerves are going to be on fire for a while.
Yeah. So, heat and tissue doesn't really go together, does it?
No, the 15 blade cut is the best way to go for good, awesome healing. Wow.
Yeah. It's the same you could say like when you're doing a turbinate reduction, as soon as you introduce heat, you start getting ENS type stuff. And then some people say that the cold knife approach with the turbinate reduction is better because it's, just cleaner.
Turbinate reduction, I use a Dean scissor, which is a facelift scissor. So I kind of hold the turbinate down and I cut right above it. But for turbinates, no more than a third. Maximum that I reduce is a third of the turbinate. If you do the full turbinate, you're going to wind up with empty nose syndrome. I wrote a paper in Baylor proceeding with Dr. Wolford. It was 603 cases retrospective. The case that we presented actually was too much reduction. We've changed our ways a lot. 80s, 90s ENTs did a ton of full turbinectomies, not realizing that histology of the soft tissue is so important for warming the air and directing it back. So because it's ciliary cells that have these hair cells that push everything back and warms the air. So it's got a function of its own. But you also, if you're moving the position of the upper jaw, you don't want to obstruct that. So if there's obstruction, we just reduce a little bit of it to have adequate amount of space, not over reduction. I am doing that less and less nowadays. So when it's needed, we do that. If we do an upper maxillary impaction, you have to open the way because you were fully otherwise obstructing the patient.
Yeah, that's fascinating. Wow. I just opened up a can of worms. I could ask you a million questions about that, but let's stay focused here. Is there anything else you wanted to show about long-term stability of these joints?
No, I think that was a really good, good series that we went through. And what you were kind of like really interested in, we were discussing before to talk about expansion of the arches and such and, our device.
Yes. So, before we get there, I just want to ask you about surgical planning with the patient, because this has been a major source of complaint with me, with patients going out and getting jaw surgery consults. Yeah. What I'm seeing is that patients will go to a surgeon and they are really concerned about getting a good aesthetic outcome. And what'll happen is a week before their surgery is scheduled to happen, a week before they go into the OR, they get their plan. And if they don't like it for whatever reason, because let's assume that not all surgeons make it perfect every time. Let's say it's not the right movement for them for whatever reason, based off some analysis they're doing independently with a private consultant or another surgeon or whatever, their own intuition. They don't like it. They tell the surgeon they don't like it, and then the surgeon says, sorry, the splint is already ordered, the custom plates are already ordered. If you want to change the plan, we have to cancel the surgery. I have to charge you another, VSP, virtual surgical planning fee.
Whoa.
And then it's like, well, I guess I just have to do whatever you suggested then, because I don't have a choice. You're not getting, it's essentially being coerced into whatever the
surgeon wants for them. It's not my face to decide for someone else. Okay. And it's not my position. I always tell patients what we do has to be a shared decision-making process. So I go over the planning with our patients prior to surgery. And this is 3 weeks prior to surgery that we do that. I mean, I like to believe that we have a different workflow than most have with this surgery, because we take a lot of time. I have a lot of staff that most folks don't want to hire and specifically do that. We don't do any teeth and titanium here. We don't take out wisdom teeth or put in implants here. Okay. All that we do is this surgery, and they were constantly on the phone. I'm constantly doing Zooms with patients to go over what we're going to be doing. If you go to the operating room, just trusting your surgeon, and like some do, I don't want to see a doc, do your best. Omakase, whatever, however it would be, the chef's choice, but it's your face. I don't agree with that. I want to educate you first on what we're going to be doing. I'm going to tell you if we're going to come forward this much, the nose is going to upturn. You're potentially going to need a rhinoplasty. I would tell them, hey, I think the chin could be a little strong for you, but we want to get the genome glossa forward. If it's too strong, later on we go and shave it down a little bit. Okay. And I always ask them, what percentage do you want it to be aesthetics? What percentage airway? Okay. Wow. And find out about a good balance between the two of them. We have a lot of conversations with our patients. And I went to my surgery. I was supposed to have a segmental. I never got it. Okay. And I mean, it was source of unhappiness for me. But so that's what I think, we gotta respect what our patients want and need, and allow them to be part of that decision. Give them a bit of control as they deserve. It's their face. They have to live with it for the rest of their life. It's not my part to dictate to a patient on what's best for them. And I listened to my patient. I had a patient from Utah. I was like, Dr. Movahed, I don't want the chin. And by all means, don't do the chin. So, okay, we're going to do a little bit more counterclockwise rotation to get the chin forward. Now, about a year or something later, she wants the chin. Okay, so I want a little stronger chin if I can. I want to improve my airway a bit more. Now, it's all her decisions. You have to work with your patient, unless it's an unreasonable, basically expectation.
Mm-hmm. And to what extent is it you who's doing the exact surgical planning, the millimeters and the fraction of a millimeter, advancement, rotation, angle of the rotation, getting cants right, making sure that there's no asymmetries in the yaw? Is that you, or is that the engineer?
No, it's us.
You don't just kick it to the engineer and say, hey, this is basically what I want. Draw this up for me.
In my opinion, if anybody does that, they have no right to do that surgery. And I'm going to be very forceful about that. And I'm going to be very aggressive about that. We spend a lot of time on our virtual planning. And you know what? And this actually was brought up to me by, both our Synthes rep and our Stryker rep that we work with. It was like, nobody spends as much time as you do. And as a matter of fact, I have the orthodontist on the planning. Not all orthodontists want to be on, but me and Dr. Moshiri, 24/7, we're on planning together. He would be unhappy to see if I did a planning without his approval, and that's exactly the guy I want to work with.
So the engineer for you is a passive recipient of your instructions. It's not someone that you outsource the design to.
No, I never outsource that. I'm going to tell them, they know my cases are mostly segmental. So basically, they know ahead of going, they set it up for me. And I was like, okay, from my clinical understanding, bring the upper jaw forward to 7.5. Okay. Now let's look at the buccal segments. Okay, Maz, do you have things together? Are you going to be able to finish this right? Let's upright this. He was like, expand this a little more. It was like, this is beyond 9-10 millimeters of expansion. Maybe we have to kind of lessen that a bit. If we upright it too much, it would be dangerous for the patient. So there's a lot of conversation and experience that goes into that. Then the amount of movement, we do, for example, for chin, we look at hold away ratio. I would say this probably would be the right place from where we're looking at. But what are your thoughts? Let's to look at the numbers. It was like the patient wants a little bit of a less strong chin, so let's go for that. And that's what we can present to the patient. And some of the patients, for example, we have a patient recently did not want a segmental, even though she could use a segmental. But we came up with both plans, presented to her. It was like, this is a segmental. This is a one piece maxilla. Okay. You're probably not going to have as good of a bite, but let's talk to your orthodontist. Can your orthodontist finish this? Orthodontist, yes. Okay, good. Here we go. Mm-hmm. It's not going to be the best bite, but it, checks the box for the patient not wanting a segmental. Mm-hmm. So, I do my best to be as malleable as possible, with our patients.
I have a client. I do sort of patient advocacy consulting, people who are considering expanders and jaw surgery. They might talk to me about what am I hearing about certain providers? What are the outcomes like with this surgeon or that orthodontist? And so I talk to a lot of patients who are getting consults for surgery and expansion and orthodontics. Yeah. I had a patient recently, and I call him a client actually, because I don't have patients. No. I have clients.
Absolutely.
But this client got a 3D plan from a prominent surgeon in Southern California, and his surgery was 5 days later. And he took the 3D plan, and he thought to himself, it looks a little canted. It looks like my smile is a little canted. And then he paid a consultant in the field, this guy, and I hope he doesn't mind me saying his name, but he shouldn't mind because he's great at what he does, and I want to give him props. He paid this guy Shuikai to essentially look at the plan. And Shuikai excels with CBCT superimpositions. He knows how to line things up perfectly. He's great with Dolphin. Yeah. He's unparalleled with that.
That's the sign of a good, engineer or surgeon, that they look at the detail of it.
Well, Shuikai is not an engineer or a surgeon. He's a layman, but he oftentimes orthodontists and surgeons will have him do superimpositions for them to try to see what the actual outcome of a procedure was. Anyway, Shuikai took this plan, and he looked at it and he said, yeah, it is, the midline is off and it's canted about a degree. Yeah. And how does that happen? How does a surgeon build a custom surgery around something that's imperfect like that?
Let me tell you a story, and I'm not going to name names. So I had a patient that from Southern California came to us, and it was like, Doc, my upper jaw and lower jaw are canted, and beautiful young lady. But its cant was so obvious, and called the surgeon. The surgeon was like, oh, if you can do a better job, go right ahead, and it was very indifferent about it. I was a little bit ticked off about that, didn't care enough about the fact that this is a real thing that you can't see. It was about 3.5 millimeter cant.
I'm sorry, 3.5 millimeter cant? That's huge.
Huge. And the patient was like, I can see it. It was like, yes, you're right. You're not crazy. And, to me, it was like, and then they were trying to convince her, don't, why are you going to do that? Just live with it. It's not your face, okay? It's the patient's face. And when a patient walks in my office, I'm not an advocate for my surgeon friend or the person I know. I'm an advocate for that person that walks into the office, because I was a patient one day, and, they deserve that at least. They deserve the truth from me or otherwise. And if I do something wrong, I own up to it. I was like, this is what's going on. You're right. Let's go to the operating room and fix this. Mm-hmm. Okay. But you got to sometimes give your surgeon a chance to do that for you. But if the surgeon denies that that's the case, then it's their problem. Okay. And I don't agree with that. So you have to just be, and the surgeon from Southern California was great guy. He's a great surgeon. I respect him, but that was not cool in my opinion.
But where's the breakdown? Where's the breakdown that led to that can't occurring in the first place? Is it in Was it the engineer's fault, or was it his?
I'll tell you what it was. That's exactly what I was going to get to. The head was not set right when they started the planning. So they felt like there was no can, but the orbits were not straight.
Yes. Because Shui Kai straightened the orbits. He got the lines right, and that's when it became really obvious, because then he made a GIF, and you could back and forth between the aligned skull and then the unaligned skull, and then it was like boom, 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 boom.
I mean, Ron, one of the things that we have to say, it's hard. It's a hard job on us because patients care about, you got to give at least a millimeter and a half of, grace to your surgeon for the midline. Let's just be honest about that. But some of the big movements, it's very hard. But at the same time, I mean, if it's 2 to 3 millimeters, good God, that's surgery. Just go back. If it's a cant that you notice, especially in a beautiful, thin young lady, it is noticeable, and she's living with that. And so you have to address it. And the rule is this: if you think about something more than 3 times a week, that's going to wear you down. You got to address it. That's actually not my rule. That is a plastic surgery rule.
I see. Yeah, I see. But you're saying a millimeter of being off on the midline, is that okay even in the planning stage? Or is that
not
something
the planning stage, because the planning stage is very hard. Sometimes how you smile, the smile could be could make it look off, or could make it look on. Okay, it is a very hard, basically, problem to decipher. Okay, a problem to fix. Excuse me, or just predict. But also, you have to be frank with your patient ahead of time. This is a plan. This is where I see the upper lip is and the lower lip, especially the cant cases. By the time things straighten out, you don't know exactly heavy cant stuff. You don't know exactly where it's going to wind up being. So you got to be a little bit understanding of that as a patient. It's so easy to take this apart and find mistakes everywhere. And as hard as we try, especially when it comes to asymmetries with me, as hard as I try, there are things that are a little bit off. Tiny bit, and I do my best to get perfection, to attain perfection, but nothing is perfect. No one's surgery is perfect. No one.
Understood.
My best surgery is not perfect.
Understood, but for these obvious midline shifts and cants that you can see even just in the hard tissue in the plan versus, if you just align the skull right, you can see that this plan is built off of misaligned skull.
Oh, yeah. So there are a couple of things when you look at the skull, a couple of the things you have to think about. Okay. This is called a foramen magnum. Okay. And
I know all about that because I have a Chiari malformation. So,
wow. That you understand that very well.
Yeah.
So then the midline that you have at a nasofrontal junction. Okay. That you're going to look at. So, and then there's also the soft tissue. You could be on with the skeleton and not be on with the soft tissue. And you have to, and we take a lot of time in this with our engineer, but working with a good engineer will help you fine tune it in. Okay. But you have to, it's not on the engineer to plan that. It's on the surgeon to make sure that the engineer is doing what they're doing right. Because ultimately the person that is the captain of the ship and running the ship is the surgeon. It's on you.
But did you just make the point that sometimes you want to be off on the hard tissue based on the soft tissue? Like, do you think it's possible this surgeon did that intentionally because of something he was seeing in the soft tissue?
I haven't seen the case, so I really can't comment on it. But sometimes you take the midline, because sometimes someone's nose could be to the side, that brings the soft tissue to the side. Okay, so you have to look at the tip of the nose too. So then, if the patient is going to get a rhinoplasty later, they can't straighten it out. Bringing the septum, the nose being to the one side to the middle, can take care of that. So you tell the patient you might need a rhinoplasty. That's the reason why my consults are 1.5 to 2 hours. I look at the patient the whole time they're sitting across from me. I sit down and evaluate it. We do a preliminary before doing any orthodontics. Then we do another planning prior to surgery. Then we go over the outcomes. Are you happy with this? Let's come back. I want to look at your midline again. I'm not happy. I'm not confident of it.
Yeah.
So you got to belabor every detail. It's kind of like being that chef that, that before you got to do your prep before making, for example, your bouillabaisse, which I think is a very tough dish to make, French dish to make. But you have to have everything ready. If things are not in order, your dish is not going to come out right.
Yeah. Yeah. You mentioned the importance of aligning the skull properly. And I know that also neck posture is this the Frankfurt line?
Frankfurt horizontal, correct.
That's an important orientation line for getting an appropriate neck posture right for determining movements. Why isn't there just a software that does that for you?
So no, you have to think about it this way. Well, actually, Materialize, I think the new software that came up with, I think does some of the stuff automatically. But the way I think about it is that most of the patients who have airway issues, what do they have? They have forward head posture. So you can't fix them to the forward head posture. Okay.
Right.
You got to fix, you got to tell them whenever we take the pictures, we want to make sure that from mid tragus to orbital floor, that is parallel to the ground. Okay. And I'm not going to tell the patients, are you going to be doing physical postural therapy afterwards? Yes or no? And if they tell me, yes, I'm going to be doing this. So I'm like, okay, we're not going to fix you to this. We're going to fix you to this. That means more advancement. But if they don't do it, but if they don't do this and they walk around like this, they're going to look prog.
Right. Wow, doc. That's a fascinating subject. Yeah, because like there's a lot of controversy around what is correct neck posture, and neck posture can change, especially if airway changes.
Yeah. So this is, one of the things that natural head position is what Bill Arnett likes. For me, a lot of our patients, especially younger patients, adapt very well. If they do the postural therapy afterwards, because if before surgery with someone with a small airway, you ask them to walk around and look in the mirror and walk around, or as you're putting on your makeup, so on and so forth, they're going to be with a forward head position. So you're not going to advance as much. But if you are with a straight neck and think about, hey, if you're going to put the work in like a ballerina, that this is straight here, you want to get rid of the hump that's been created here because of the OSA and forward head position, which most of my patients have, because TMD patients have that, OSA patients have that. Okay?
Yeah.
Then we're going to start here. I'm going to measure you from here.
And then that means a bigger advancement without looking prog.
Exactly.
So you're saying Bill Arnett thought about this neck posture thing? Or is he the opposite?
Bill doesn't go with, and Mike Gunson, they don't go with Frankfurt horizontal. They mostly go with basically natural head position. I might be wrong though. I went to their course 16 years ago.
And by natural head position, you mean like the compensated head position that the airway patients develop? They kind of they plan to that?
I foresee a future for the patient that the Frankfurt horizontal is straight and their neck is straight. Okay. That's the way I would do it. That's the reason why it takes a village to fix these patients. Okay. You need a postural physical therapist. You need one. My functional therapist, I've grown to really think of that as a very important component of what we do, especially with patients with anterior open bite. You've got to get the tongue strong prior to surgery. Those patients do the best. And I see it day in, day out. It's so obvious. You have to keep expansion in mind. Don't go to surgery without orthodontics, because when you go to surgery without orthodontics, we haven't uprighted the teeth. You haven't leveled the line properly. So you can do a segmental and expand the upper jaw, for that patient. So I really, unless I have no choice and the patient can't open, we're doing orthodontics prior to surgery. I don't have to get the patient. I would never do that. I would never rush a patient to the operating room unless it's absolutely pain and necessity for it.
Yeah. Yeah. So you mentioned you like to have Frankfurt horizontal, flat to the earth in your part of your pre-surgical orientation. Yeah. What are the other key cephalometric lines that you like to draw?
So let's just talk about it. Okay. The way that I go about it is this. I work from the soft tissue back, and I barely have looked at any base of skull analysis.
What does that mean? That means
like Steiner analysis or evaluation of. So to me, it's McNamara has probably one of the best planning. I'll do like McLaughlin's that basically Arnett and Gunson use. I am a fan of that, but I really reduced most of it to, hey, where is this soft tissue supposed to be here? And at what point am I engaging a nose that the nose is upturning? Okay. So now I know how much the upper jaw is going to come forward. Then I look at the occlusal plane. I've corrected the occlusal plane. Then I see where the pygonion is going to be in relationship to the, pygonion is supposed to be a hard tissue pygonion. It's supposed to be in relation to the, buccal aspect of incisor. For males, along with that line. For females, about 4 millimeters back. But
Right. And
everyone is different again. Everyone's expectations are different.
And all of that is done with the Frankfurt horizontal line flat to the earth so you can get
Correct.
neck posture right.
Absolutely. And I usually go, if this is a porion, which would be the opening right here, I usually go at the lower 1/3.
Interesting.
Okay. Orbital floor, mid-tragus, that would be the soft tissue reference that I have. Otherwise, the lower 1/3.
Wow.
But you know what? Everyone has their own way of going about it. If you're getting the results, if you're getting the aesthetic results and you have a point of reference, that's fantastic.
Yeah.
Whatever works for you.
Wow. But
That's how I've done it.
yeah, but you can imagine if just to drive home this point about neck posture, a lot of what you were saying depends on where the soft tissue pogonion and this point is going to land with respect to a line that you're drawing straight down. But if your neck posture changes, that all changes.
100%. Exactly. So if you look at someone's face in this fashion, you're going to lose.
Yeah, because you're not going to advance them so much before they cross that vertical line.
Mm.
So when you have them tuck their chin, then you can advance them more.
Yes.
Without still getting to that right point in that line.
Correct.
And so what book do you recommend to learn this stuff?
Oh my God, that's a tough one. I might have to get back to you on that one.
Well, you mentioned two analysis. There's McNamara and then there's...
Yeah. So McNamara, I would say McNamara analysis is the closest one to what I like.
That's similar to the Arnett analysis?
That's McLaughlin.
Oh, okay.
That's the orthodontist that they reference as McLaughlin.
Okay. You like McNamara.
I'm a big fan of Dr. McNamara. I think he's actually one of the greatest orthodontists ever because he's published so many amazing papers. I'm a huge fan of the man.
Yeah, amazing.
When it comes to aesthetics, for me, is Dr. Sarver. I love the aesthetics of a dentition that Dr. Sarver does, and of course, I have my bias. Maz, who I work with above and beyond. Maz actually works with Dr. Sarver quite a bit. The bites that I get with Dr. Ferrari are amazing. As I mentioned to you, Dr. Noaz, it's just really awesome orthodontists that I have, the ability to work with. So I'm very excited about working with a group of people that are perfectionists. They think about the aesthetics, the bite, the airway all together. Yes.
Well, that's good. We'll leave it at that. Maz is Dr. Moshiri, by the way, right?
Yes. I'm so sorry, Dr. Moshiri.
No, it's okay. I worked it out. Well, speaking of Dr. Noaz, right? Let's shift gears to expansion.
Sure.
And the reason I say Dr. Noaz, well, because he mentioned to me in my podcast that I did with him last weekend that he was considering consulting with you about your MSDO procedure to expand his mandible after his pretty large maxillary expansion with FME.
Sure.
So I would say 75% of my content is actually about skeletal expansion, not about jaw surgery.
Yes.
And obviously the big question with skeletal expansion is how do we deal with the limit that the mandible sets on maxillary expansion? Because obviously you have to preserve bite and facial aesthetics, et cetera, et cetera. So you can't expand to infinity on the maxilla. Not that you would want to for a variety of reasons. I think big expansions are quite ugly, actually. But the mandible, mostly what people do is they just tip the bag out of the lower teeth out.
Yes.
Or they do that on steroids with SFOT. Dr. Yousefian has talked to me about mandibular skeletal expansion before, but you have your own version of that. So why don't you tell us about that?
So let's go through this because I think it gives you a really good background about this.
Yeah.
So this is a paper by Dr. Silva Chamberlain, and this is the first time that I noticed anyone relate maxillomandibular expansion with airway. So as you can see here, the paper that he published, he presented 2 cases, and he mentions that MME, maxillomandibular expansion, could make the results of the MMA better than MMA alone. So he presented 2 cases. He lost 2 incisors. Not a big deal for what you want to do. It's an easy fix, an implant in the middle, but he used a Bologna distractor, which is a KLS distractor. I use this a lot. It breaks less than the Rotterdam But these are 20-something-year-old devices. That's the reason why I wanted to come up with a device that's easier. This is on the buccal. The one that I came up with is on the lingual. And this patient had SARPI MSTO and ultimately wound up with a better airway and improvement in AHI scores. So we don't have long-term results of this, but this has helped. But we're going to look at our airway changes as well. And this patient here had also had MARPI and MSTO, which is, again, with a Bologna system. So with a Bologna system, you do a surgery to put it in and a surgery to take it out. With the device that we have, it's only putting it in and making the cut, closing everything up. It's on the lingual, and we'll see that in just a moment. So maxillomandibular expansion for pediatric syndromic group, it's been done for a long time. RME in the upper jaw, rapid maxillary expansion, as well as the symphysial distraction, imperial band, and hemifacial microsomia cases.
So that's tooth-borne expansion on the top and then skeletal expansion on the bottom?
Yes, because obviously for kids, you can expand the upper jaw with just pressure on the teeth, but a symphysial distractor, different story.
Right. And, there's no suture on the mandible that you can leverage even at that young age.
Absolutely. And it is important. We miss that in basically cases of the syndromic cases. So, this was one of our earlier cases, the Bologna in the lower midline cut. And we did the actual cut in the upper jaw and did a MARPI in the upper jaw and expanded the upper jaw and lower jaw. And then ultimately went on to MMA. So this is one of the cases, but, let's take a look at this case. This was a gentleman who presented to us about 4 years ago, and have Asian descent, it's very hard to do heavy movements for him for MMA. So we were like, okay, we have to really increase the other dimension would be the transverse dimension. So maxillary
why is that with East Asian patients, doc? Because they have there's a flatter midface generally with that class of patients.
Correct. It's just cephalometrics are that way, and the noses are smaller. And when you do a bit of movement, the response of the nose is very acute. The nose rotates up too much, and that's nothing that any patient would want. But in this case, we used the Bologna distractor. We did about 10 millimeters in the upper jaw and lower jaw expansion, because otherwise the teeth had to be tipped out to meet the expansion of the upper. And you can see the expansion that happened here. And this is when we took the basically distractor out. This is something we don't have to do anymore with our distraction system. The joints look great, no issues. And intermolar width went from 29 to 40, basically.
Mandibular intermolar width.
Yes, correct.
Oh, that's crazy, because you wouldn't think that you would get that much, because, with the vector of the expansion, you think most of the expansion is at the anterior.
I might be wrong, but I think it might have been more than 10 millimeters that we expanded lower. So it translated as such.
Okay.
So now take a look here. So the MCA, minimal cross-sectional area, went from 25 to 122 by mere expansion of the upper jaw and lower jaw. And now the airway is wider from the front. Okay. Now, when we did the MMA, we went to 194. So I don't think we would have gotten this kind of an airway if we didn't do the MME.
Because you could only advance him so much. It was probably a pretty modest MMA, right?
It was actually 7 millimeters.
That's very modest.
Very modest. But we were able to get this result. And Dr. Chamberlain is right. I think we get a better airway if we do the MME. This is another case, recent case, MME to be followed by MMA for this patient. Actually, we haven't, we're going to bypass that case, and I'm going to show you our distractor, as a matter of fact.
Can I just pause briefly to ask you a question? Dr. Gunson's criticism of sometimes doing expansion prior to surgery is that he thinks that if there's not a pre-existing arch length deficiency, meaning that there's no crooked teeth or no teeth pushed out to the perimeter, to the edge of the bone, that, if there's already plenty of bone to support the teeth that are there, that you can end up with arch length excess, and that can be unesthetic, right? Because you have too much bone for not enough teeth.
I would say, I had a patient just recently that was expanded too much and just doesn't fit her face. It's got to fit the patient.
Yeah.
It's got to fit their symptoms and such.
So you're saying it's about dose?
About what?
Dose. It's about dose. It's about how much expansion and mitigating that problem.
Yes. I mean, there's a level that I'm willing to go, whatever makes sense for the patient. But as long as the teeth are uprighted on the bone, and you just have to, and it's if it's a 40 millimeter in a molar width, just do the Marpy in the upper jaw. Okay. But if you, as I showed you in that case with the Asian young gentleman, so for him, we had to maximize both vectors. Okay. So we had to maximize the width and AP.
Yeah.
But the AP we had limitations. So I really wanted to give him the best, because one of the things that happens, for example, with this device, is that when we make the cut, the mylohyoid is stretched, and so is the genuglossal muscle. So you're not only pushing the teeth and getting the teeth out, you're stretching the muscles. Okay.
This is your proprietary device?
Yes, patent pending. And this is what we work with, Jamil from Partners Dental. I was so lucky that he partnered up with us to put our thought process into work. And this is what I started with Kalos Martin. They couldn't get it FDA approved. I really wanted to use the Zurich distractor that you can see right there, but I was too big, and the arm on the lower right side was 5 millimeters longer than we wanted to be. I've been working on this for 7 years, because when the Rotterdam and Bologna's broke right and left from me and got me in trouble, I was like, I have to come up with a new idea. And that's why I came up with a lingual one, which makes sense. Okay. Because it is much easier for the patient to basically clean, deal with, and such. So if you look here, 1 second, there we go. All right. So the way that we go about this, everything is CT guided for where the screws go in. Okay. And, there's the interdental. We're not hitting any nerves, nothing. So 3 screws on each side and stabilize. And it's also stabilized to the teeth as well. Okay. So this, as I mentioned, this took, years, to, put together.
Wow.
That's the reason why we're patenting it. And because it has to be sturdy, stable, and such. And when it's oblique, you can put in 17 to 18 millimeter, screws in some cases.
Yeah.
So
the oblique gets you more grab from the screw, because you get more surface area contact between the screw and the bone.
I mean, like in a 3D world that we have now, with a kind of conduit that we have, we really know how not to hit the roots. And we go first with a pilot drill, and if the teeth are in the way, you would know, okay, you stop right away. But otherwise, with the design of this, it's unbelievable. And that conduit is going to guide your drill in the right place. So it makes it fairly, fairly foolproof, so you're doing things right. And this is what it looks like. And it has a Hyrax in the middle. So ultimately what we do, make that cut in the middle, the device is placed, and then you do the expansion in the upper jaw and lower jaw.
Wow.
Okay. We lost actually 2 central incisors in this patient, mainly because of the fact we wound up with external root resorption. So now we're moving the lateral incisor in place of the centrals, and we're going to put 2 implants on the side. But this patient had canines extracted in the upper jaw. So what we wanted to do is to get the canines open and back. As you can see, the space is minimal for her. She's going to go ahead.
Why do you lose centrals with this mandibular expansion so much?
So we moved the teeth to the middle a little too late in this case. We're still learning some of this. Okay. And I'm very transparent with our outcomes. This is we've lost 4 teeth out of 24 cases. Okay. So it's not related to damaging the teeth during the symphysial cut.
No. It's about
periodontally.
Because when you separate the mandible, you lose bone, and then the tooth loses its bony support.
The patients had thinner bone, and what we're doing now with Dr. Mandibular is to SFOT the site, so we have better soft tissue and bone.
Oh.
So we're you know what? MSE and MARPI had their problems in the beginning, but we're figuring this out. What we explain to our patients what's happening. So what could potentially happen, and we don't move forward without mentioning that. That's the reason why we're very selective about these patients, and we want to figure out some of these issues. And everybody should know that that's, you know, that other than that, we haven't had any other complications.
Mm-hmm.
So this is another patient that's recent. This is from when we started to post MMA, and this is where we started. We have what we have here now is the MARPI in the upper jaw, and also the symphysial distracted in the lower. You can see the gap that we have. Now, this is after double jaw surgery. That's the Z and L plate that I was telling you about that we use.
Oh, what is the Z and L plate? Can you point to that?
Sure. The Z and L plate for the sagittal split. If you look, our sagittal split has this kind of a cut with a step.
Interesting.
Okay. But what was so amazing, take a look at this. So the MCA, just by expansion of the upper jaw and lower jaw, went from 103 to 233. Look from the front, how the airway is so much wider.
Mm.
That is sculpting the airway, getting it ready for a successful MMA.
And to be clear, because a lot of people will criticize these minimal cross-sectional area comparisons in the befores and afters based on changes in head posture, right?
Sure.
But from the front view, that's less affected by neck posture, right?
Yes. That's it. Forget about the numbers. Just look at the width of that airway.
And that's really what you're showing here. You're showing the widening of the airway from the frontal view.
Because the patient is planned for MMA anyway, so we're going to get to AP. Yeah. And here comes the AP. To 300, okay? And so I think that was the part that was so important for us to talk about, to mention that when you do this symphysial distraction, what are you doing? It's not just pushing the teeth. You're also widening the muscles, stretching the muscles, give it more stability. So that's the reason why Dr. Chamberlain mentioned that MMA by itself might not be as effective as MME followed by MMA. Yeah.
I got to tell you a funny story about Dr. Chamberlain. Like probably 5 years ago, when I was getting into skeletal expansion stuff, I found that his paper online just from Googling back before any of it was really popular. It wasn't popular at all. And I just called his office and I was like, can I talk to Dr. Chamberlain? And the woman who picked up was like, yeah, sure. And Dr. Chamberlain gets on the phone. I'm like, oh, holy shit. And
me too. I did the same thing.
Really?
I called his office. I wanted to get him to speak for our meeting, as a matter of fact. And he was like, why would you want me to speak for your meeting? And what's going on? But go ahead. Let's hear yours.
Yeah. Same react. I was like, hey doc, would you be willing to do this mandibular expansion for this, MSE expansion that I'm doing?
Yeah.
And he was like, I can't do this with you over the phone. This is ridiculous. No,
I know. He's very
strict
by
the book.
Straight. Yes.
Yeah.
Yes.
He's, I don't even think I don't want to say he's not that interested in, the publicized airway space stuff, but I think he likes to fly under the radar and very conventional. So it was this irony because he's doing this very cutting edge thing, which is mandibular skeletal expansion with MARPI. And yet, so I thought he was going to be this very progressive kind of person.
No, and then I got him, man.
Oh man. I respected it.
So he published with Dr. Prophet also quite a bit. But he is very much old school.
Yeah, he's a hard ass, but I respect it though.
Yeah, me too. Awesome.
Well, so then tell us about mandibular expansion in the joint, since you're the joint guy.
Yeah. So, the joints that we've seen thus far, none of the joints have been affected,
But isn't the condyle
rotating? Because we're going slower and we really slowed our movement. Thus far, we haven't seen anything.
theoretically, though, do you think this is healthy for the joints?
I haven't seen any breakdown of the condyle yet.
But this would be bad, right?
That would be bad. Yes. That would be the condyle then would go towards the medial pole. That would be much worse.
And so is a big part of designing these mandibular expanders controlling.
So listen, what we're doing actually, we're doing a full-on study on the first 10 cases, and that's going to be at St. Louis University. That definitely is going to be a publication because this has a lot of interest, but I want to go slow, methodically, figure out the kinks for everybody, select the patients right. And once we have, the final set of everything, then publish it. But this needs to be published because nobody has made a distractor like this.
Yeah. And then obviously with Jamil at Partners Dental being involved, it's very well positioned to be efficiently distributed to all of the top MARPI providers.
Yeah.
Right? Because it's the same
absolutely.
lab.
Dr. Robley has a major interest. Okay. He's a savant when it comes to expansion. And he says he's not happy with the fact that he's tipping the teeth. So I'm excited working with him on this as well, because he's definitely a perfectionist when it comes to anything that he does. So would be amazing.
Do you think Jamil's experience with locating custom MARPI screws in the perfect spots helped him
it
get
was
yours
so
right?
paramount. I got in touch with so many labs and the person that was on board with Jamil, and I'm so excited to work with him. Him and Dr. Kim from St. Louis University. The three of us are basically on the patent together. The idea I started 7 years ago with KLS Martin. I was hoping it would have been KLS Martin, but I think we have a better situation now because this custom made device is just awesome.
Yeah. That's incredible, Doc. I think that's very exciting for all people interested in MARPI, knowing that there's potentially a real substantial solution to the lower jaw. We're coming up on 4 hours, Doc.
Yeah, I know. I'm getting called to go and see patients now. But
yeah, and my wife probably thinks I had a heart attack up here. I want to thank you for your time and for the incredible conversation and for all that you do. Really appreciate it, Doc. And let's be in touch, okay?
Oh, thank you so much.
Okay, Doc.
Great talk.
Thank you, Dr. Movahed. Bye-bye.
Have a great day. Thanks so much. Okay, bye-bye.